right. Well, good morning. How is everybody on this cold, wet, nasty day? My colleague Jessica and I were just talking about the question of whether it's better to have a conference on a Saturday when it's cold, nasty, and rainy outside, where it's not so bad to be inside, or whether it's sunny and easy to get here. I rode my bike here this morning and got soaking wet, but it's nice to be inside, nice and warm and cozy, and even more importantly, to be here with a lot of friends and colleagues. And, as part of my welcome, I'd like to acknowledge all of you that made the trek to come here today to our conference on peripheral neuropathy. And I particularly would like to thank and acknowledge the Foundation for Peripheral Neuropathy, and I'll be introducing Lindsay and Lou in just a couple of minutes, so we'll talk a little bit about the foundation. But in a sense, this is a collaboration between the Mount Sinai Medical Center, the Icahn School of Medicine at Mount Sinai, where you are right now, and the Foundation for Peripheral Neuropathy, to do something that's a bit different. I think for most of us in the field, when we give a talk on any medical topic, including neuropathy, we're speaking to colleagues, mostly physicians. And today, the approach we're taking is to bring this directly to our patients, families, caregivers, loved ones, and other interested parties. But we're going to try very hard, and I hope successfully, to make the information relevant, comprehensive, but also understandable. And I apologize up front if some of the information borders on the technical. We've tried to, bring it to a lay level. But if there are any questions, there's going to be plenty of time for discussion and Q&A. Now, up here we have the agenda, and I'll just walk through it quickly. And as we go through, I'll be introducing the individuals. After I say my opening comments, I'm going to welcome Lindsay Colbert up to the front, who is the Executive Director of the Foundation for Peripheral Neuropathy, and she'll be introducing Lou Mazoui, who is the board president of the foundation. Then I'll come back and I'll introduce the topic of peripheral neuropathy. And I'll talk a bit about an overview of neuropathy and some of the medications we use to treat neuropathy, some of which many of you have tried. Then I'll be introducing Dr. Jessica Robinson-Papp, a colleague of mine in the Department of Neurology here at Mount Sinai. And Jessica is going to talk about a very hot topic, which is the role of opioids and medical marijuana in the treatment of neuropathic pain. I suspect many of you have heard about this subject, perhaps even tried some of these substances. We'll then have a Q&A, question and answer, with the faculty. We'll take a break at 10:15, but certainly all of you should feel free to come up and go down and get more food and coffee as you wish. Bathrooms are right outside. Then we'll have Dr. Shanna Patterson, another colleague of ours here in our Department of Neurology in Mount Sinai. And Shanna will talk about communication. That is, how do we talk between patient and provider, as well as other approaches to treatment, that is, non-drug treatments or non-pharmacologic treatments of neuropathic pain. Then finally, Mary Catherine George, sitting in the back there, who has got a touch of a cold today. And so if her voice starts breaking, you'll know why. But Mary Catherine, I thank you for your resilience in coming in today. And Mary Catherine has been a cherished colleague of ours for many, many years, working with us as our research program coordinator, and also is in the process of doing her PhD thesis in pain, particularly with focus on neuropathic pain. And she and Dr. Dorfman and others in the department are working on very interesting new technical strategies using computer-based apps, iPhone apps, to optimize communication, record pain, and Mary Catherine will talk to you a bit about that. We'll end with a bit of a Q&A, and any questions that any of you have, we certainly want to answer either in a direct communication with us on the podium, or certainly during the breaks and outside, we'll all be happy to talk. And then we'll break at about 12:15 or so and adjourn the conference. And so with that, I will introduce and turn things over to Lindsay Colbert, the Executive Director of the Foundation for Peripheral Neuropathy. Lindsay has been putting her tremendous time and effort into keeping this foundation on track with all the different activities that they're involved in. And I'm sure Lindsay will tell us a little bit more about that. Thank you all for coming.
Thank you, Dr. Simpson, and thank you everyone for coming here. I know the weather isn't great, but for those of you who made a longer or even short commute for it, we really appreciate it. So as Dr. Simpson mentioned, I'm the Executive Director of the Foundation for Peripheral Neuropathy. We are a nonprofit organization based in Chicago, and we're thrilled to be here in New York to be able to provide a conference like this, teaming up with Mount Sinai, of whom is actually one of our partners for our biobank, our research registry, which is a very big, important program that we're doing to help promote research to advance treatments and hopefully one day find cures for peripheral neuropathy. And among research, we also have a lot of awareness programs. We do a lot of different support for patients. So anyway, at the end of the day, if there's anything you guys ever need with respect to treatment plans or questions about symptoms or what have you, needing to find a neurologist in your area, even if it's not here in New York, please reach out to us. That's really what we're here for. We're here to support you and provide programs such as this for patient education to really make sure that everyone truly understands what neuropathy is and bring more awareness both to the condition and to the foundation. So we're really excited about this program. As Dr. Simpson mentioned, we have a fantastic lineup. At any point, if you have any questions, let us know. We do have a couple of breaks and question and answers specifically set within the agenda, so if you could try to hold off until then, we'd appreciate it. But if at any point you can't hear us, or if something's really confusing, please don't wait until the very end because you might have missed a whole bunch of stuff in the interim. Secondly, I'd love to thank our sponsors for helping us with this event. Allard, Alnylam, New Factor, and Curaleaf are all here in attendance. We do have representatives here for each of them, as well as various materials located in the back of the room. So during the breaks or following the conference, if you haven't already and you're interested in connecting with them and asking questions about what they offer and learning a little bit more about their organizations, I'd encourage you to do so. And again, thank you so much for those sponsors, from those four organizations. Next, I'll turn the microphone over to Mr. Mazawey. Lou is our board president. He is based out of Washington, D.C. He practices law with Groom Law. He was diagnosed with peripheral neuropathy in 2003. He has a rare autoimmune form of neuropathy known as anti-MAG. And I'm sure he'd be more than happy to chat with any of you to help educate you or explain some of the symptoms he has and how he copes and manages, as well as offer some advice on techniques that might work for you. But at this time, I would love to welcome Mr. Mazawey up to the podium to say a few remarks before we get started with the program. Thank you all again for coming.
Yes, welcome everybody. I'm Lou Mazawey. You probably said, oh, we have enough of the intro remarks, let's just get moving. But anyway, this will be quick. And New York is my old stomping ground. I went to NYU undergrad and then migrated down to DC. But it's been, this is finishing up my second year as president of the foundation. And it's been a tremendous, we have a tremendous staff, and this is our third patient conference. It's something that we decided to do as a way to outreach to folks like you and provide an opportunity to have firsthand interaction with the experts. And I think today's program, everyone has been a little bit different. Today's, which was put together by Dr. Simpson and his team, we're so grateful to, is really, I think it's great because it focuses on, many of us, not all, that have PN have neuropathic pain. When we have it, it's pretty bad, and we want to know how to manage it, how to live with it. Are there prospects for better treatment? So all of these things are going to be discussed today, and I think it'll be very useful. And, I've been dealing with my PN, as Lindsay mentioned, for 15 years now. And I'm always excited to learn more because it's been life-changing for me in many ways. But, you have to do your best with what you have and try to keep improving or at least not getting worse, and try not to get discouraged. And those things are all, attitude, those things are so important. And I just want to put a plug in. If you're not a member of the F Foundation, or we're running a sort of promotion. I'm matching new memberships. It's only $30. It's really not a lot, and you get extra content, discounts on programs like today's, for example. And it's open for another week, and so I urge you to donate. And finally, I just wanted to say a brief note of thanks to Lindsay, Nancy, and Angela for their terrific work on the conference and every day in Chicago for the foundation. So thank you all, and I look forward to hearing Dr. Simpson and his team. Yeah.
All right. Well, now we'll get into the heart of the matter. And in terms of organizing today's talks, we thought we would focus on one of the most troubling symptoms of neuropathy, and that's pain. Now, that's not to say that every patient with neuropathy has pain. In fact, as part of the Peripheral Neuropathy Foundation, we're recruiting a large study, a so-called cohort study, in which we're inviting patients who we're following as their doctors to join into this research study where we evaluate and follow individuals and capture their data in order to learn as much as we can about neuropathy. And one of the things we look at is, why do some people have pain and others do not? It's a fascinating problem that we haven't completely figured out. But as we go through the day, you'll see that many of the talks, all of them in fact, will have a focus on pain, but if you're interested in other aspects of neuropathy, we can talk about that as well. Now, one of the first questions to address is, what is neuropathic pain? And it's confusing, particularly for those not in the medical field, because pain can happen from so many things. And one of the distinctions that we often make is what is called nociceptive pain versus neuropathic pain. Everybody here has had an injury. You sprain your ankle, or you fall and you hurt your arm, maybe even break a bone. That type of injury is called nociceptive pain, which is damage to tissue. You break your arm, you get an x-ray, the arm hurts. On the other side, we have neuropathic pain. This is pain induced by a primary problem of the nervous system. For example, diabetic neuropathy or HIV neuropathy, shingles, postherpetic neuralgia pain, and then even some forms of low back pain like sciatica going down the leg. These are what we're going to talk about today, neuropathic pain. Now, the other thing about neuropathy, which sometimes is confusing, is not all neuropathies are the same. And one of the things we try to teach our colleagues, particularly in primary care, GPs, is that it's not just one big basket of neuropathy all looking the same. In fact, you see in red here, shaded, are different patterns of neuropathy symptoms. Many of you are probably familiar with this so-called distal symmetric pattern. We sometimes call that stocking and glove, because patients feel like they're wearing stockings and glove, or they have pain in that area. You may have one part of a limb affected, like carpal tunnel syndrome, one arm and one leg, a whole arm, or even the whole body, such as in Guillain-Barré or CIDP. Now, the final common pathway is damage to the nerve. So here we have the skin, here we have the spinal cord, and here we have the brain. And let's say you burn your finger, the impulse travels through the peripheral nerve, into the spinal cord, up to the brain, and that's how one ultimately perceives pain. Now, when we think of neuropathy or neuropathic pain, there are many, many different causes, scores of causes. And one of the most important things we do diagnostically is not just treat the pain, but try to understand, is there an underlying cause of the neuropathy that we can address? For example, diseases, infection like HIV, or tumors, metabolic problems like diabetes, trauma, injuries. There are things that we do to patients like surgery or cancer chemotherapy or radiation damages nerve. And then there's a large group of genetic disorders, hereditary neuropathy, and all of them may cause neuropathic pain. Now, how common are these different problems? And it's hard to get good numbers, and this comes from an old study. But here you see amongst the recognized causes of neuropathy, diabetes is one of the very most common. Post-traumatic neuralgia, shingles, cancer pain. And then look here in green. What is this big green part? Over half, low back pain. Now, we could easily have a whole conference today on low back pain. I suspect everyone in this room has had it. I certainly have had it. And is it neuropathic? Well, it depends. Certainly if you have sciatica with pain shooting down the leg, most of us would say that is neuropathic. Just an ache in your low back maybe is a more tricky question. Well, anyone who's had pain knows what a disabling symptom is. And here you see just a couple of pictures. In fact, this one particularly is probably very reminiscent for some of you of what your feet feel like when you're experiencing this neuropathic pain, like nails or tacks going into the feet. So what are some of the challenges that we have in dealing with neuropathy? Well, we know it's very common of individuals going to any clinic, including a primary care. 25 to 50% of patients report pain as a prominent or primary symptom. We don't do very well as physicians either assessing or treating. One of the questions I'm sure many of you would acknowledge is, are you believed? If you tell the doc, I've got pain, sometimes the doc says, are they trying to get drugs from me? Is this pain real? They don't look like they're hurting. The pathophysiology, what's the cause? We don't understand as well as we need to. The treatments we have some good treatments, and we'll talk about them today, but they're certainly not ideal. Part of what's going on in the foundation is seeking understanding of neuropathy to lead to better treatments. And even when we have good treatments, not everybody responds the same. I could give one treatment to you and another treatment to you. It may work for you and not for you. Why is that? Now, when we think of the complexity of pain for the individual, first we have what we call the nociceptive stimulus. I burn my finger on a stove. That excites the nerve endings in my fingers, the so-called nociceptive receptors. Then there's the perception. The pain signal needs to get up to the brain where we can perceive it. Then we have suffering. And finally, we have behavior. And each of these is a step leading to what ultimately the patient walks in with to the doctor as an expression of their pain. Now, I'm going to talk a little bit about a couple of types of neuropathy, starting with diabetes. Now, I think many of you know that there is an epidemic of obesity worldwide. And here we see from 1994 to 2004, an old slide now, but the trends are here, in which in red, you see the growing rate of diabetes. All those nice bagels we have out there on the table, or walk down the street and find Popeyes or Kentucky Fried Chicken or McDonald's, particularly in the inner city, is where this is a big, big problem with the bad diet and fast food. Now, if we look at neuropathy with diabetes, and again, these are old numbers, but they're just here to give you an idea. If we think of the number of people in the US with diagnosed diabetes in the order of 21 million, and this is old numbers, you'll see different estimates on how many people with neuropathy, how many people with diabetes have neuropathy. One estimate is 20 to 25%. 10 to 20% of those neuropathy patients have pain severe enough to require treatment, and that brings us to about 1 million individuals requiring treatment for diabetic neuropathy. Now, what are some of the risk factors for diabetic neuropathy? One of the most important is age. And this is true for almost every type of neuropathy. As we get older, our nervous systems are more vulnerable to dementia and neuropathy. Duration of diabetes, control of blood sugar. Interestingly, hypertension, cholesterol, smoking, the same risk factors one has for stroke and heart attack, also are risk factors for diabetic neuropathy, possibly because the blood vessels may be one of the problems. Now, how does the patient look? Well, when we think of this so-called stocking and glove neuropathy, pain, that could be burning, shooting, or stabbing. It's worse with activity, particularly walking. Often it's worse at night, lying in bed. Pins and needles, or what we call paresthesia, very common. Increased sensitivity. For example, when one puts on socks or a coat, the contact with the skin can be very painful. Numbness, a negative symptom, and balance problems all affect individuals. Now, there are data in the research literature showing that control of sugar can both reduce the risk of developing neuropathy, so-called primary prevention, or reduce the risk of worsening or progression of neuropathy, so-called secondary prevention. So one of the things we emphasize is good glucose control. Not overly tight, because that could lead to other problems that we won't talk about today. Now, when the docs are assessing the patient, what are the goals? Well, pain needs to be addressed and assessed. Causes of neuropathy. We have many patients coming in with so-called idiopathic, meaning no cause known, and then with a thorough workup, including blood tests and the like, we often uncover a cause that wasn't known before. Evaluate other conditions like depression, psychosocial factors, how is the patient functioning, and then set realistic goals. We're not necessarily trying to obliterate pain, we're trying to improve function even with persistent pain, and oftentimes when to refer to a specialist. The specialists aren't always around or available, but certainly if you can get to a neuropathy specialist, all the better. And when you think of the different members of the team, the medical team that may be involved with an individual, this is often complex. You have pain specialists, neurologists, physiatrists, which are rehabilitation docs, psychologists, occupational and physical therapists, social workers, nurses, and all of these individuals may contribute to the care of the patient. Well, the challenge of measuring pain. You go into your doc saying, I hurt. Now, yes, that's helpful, but how much do you hurt? If we're doing research on a new drug, how do we know what to measure to say this drug really works? Well, we need to assess the pain, its type, distribution, the state, what treatment the patient's getting, and what tools we can use to measure. Well, here's Grandpa coming in to the doc, and doc says, "How much do you hurt?" And they say, "Ouch, damn, ow, ooh, ah." And this is the way patients describe their pain, ouch. But we can put numbers on it. And here are a few of the scales that if any of you have been involved in research, you're often asked to fill out, from no pain to worst possible, put a number from 0 to 10, put a bar or a line where the pain is, and even a FACES scale for individuals with less literacy. An interesting challenge, particularly in the research world, is what happens over the course of 24 hours. Let's say we're doing a research study and we want individuals to give us a number every day of their pain in a diary or some such thing. Well, if I ask any of you in this room who have pain, tell me what your pain was like over the last day or the last 24 hours, and give me a single number. How accurate is that? Is it even possible? When we see from some studies that the pain fluctuates over the course of the day. And so individuals often try to do a gestalt. Some will give the maximum, some the average, but it's a challenge that sometimes we don't have a great answer for in the research world. Now, the other interesting question is not just how bad is your pain, but what is the quality of the pain? What does it feel like? Sharp or stabbing, hot and burning, electrical or shocking? And there's some interesting research to suggest that some of the mechanisms underlying these qualities may be different nerve types, and it may be that treatments work better for some types than for others. There's a lot more that needs to be done in this area. Now, when you go to your doctor and you're being evaluated for neuropathy, one of the things that often is done is a workup. And you often say, why all these tests? Why all these blood tests and EMGs and skin biopsies? All of these tests are getting to the heart of understanding both the cause of the neuropathy. Well, even back, do you have neuropathy? There are many people with burning feet in whom we're not even sure if it's neuropathy. Maybe it's circulatory, maybe it's gout, maybe it's arthritis. Not all feet pain is neuropathy, and diagnosis is very important. But then once we know it's neuropathy, then the tests start. Blood tests are critical. As I mentioned, sometimes the blood test will uncover a problem, like Lou mentioned earlier, anti-MAG neuropathy. I could guarantee you that the vast majority of primary care docs never heard of MAG, have no idea what MAG is, and certainly would never order the test. And until you get to a neuropathy specialist, they're the ones who know, you know what? Let's look for some even rare causes of neuropathy, because if it's discovered, it may go a long way toward helping a proper treatment. EMG testing, those funny shocks, the electricity, the needles going into muscles, not the most fun test in the world. Jessica, Shannon, and I all do EMG testing, and it can be very, very important. Not for everybody, but for many people. Now, the problem with EMG is sometimes the EMG test is normal, even in folks with neuropathy. And why is that? Because there is a type called small fiber neuropathy that isn't tested by the EMG. And how do we diagnose small fiber neuropathy? Is with a skin biopsy. And some of you may have undergone that to look at the small nerve fibers. Now, for the remainder of my talk, I'm going to discuss treatment. And it's going to be a lightning fly-through. I'm not going to go through a lot of detail, because that in and of itself could be a whole talk. But one of the first points to mention is undertreatment of pain persists despite decades of effort to provide clinician with proper education. Pain management is challenging. Many docs don't do it very well, and frankly, many docs don't want to do it. Here's an interesting quote that I think is very relevant to any of us that have had pain. To experience pain is to have certainty. To hear about pain is to have doubt. And remember I talked earlier about patients not being believed? Well, this gets to the heart of that. Anytime you put on the news, read the newspaper, you're going to read many, many articles and hear stories about the challenge and the traps and the abuse in the pain treatment world. Just over the last couple of days, there was a story in the press about a number of physicians who have been indicted on their prescribing practices of opioids. And it's become a bigger and bigger problem, but that's one of the reasons why many docs don't want to deal with pain, because they don't want to get into those traps. What are some of the barriers? Patients may not want to report their pain. They may either have a history of substance abuse, or they may not want to be seen as seeking drugs. Many docs will say, this person's talking to me about their pain, they want me to prescribe drugs and they're going to sell them or abuse them. The healthcare providers are fearful of turning people into addicts. Sometimes the fear is justified, often it's not. Or they are worried about being scammed. And the healthcare system is putting more and more restrictions on pain management. And here's an example of the OxyContin controversy, one of the big problems, the big abused drugs in the community. And here's a doc in Florida who is running a pill mill that was put in jail for his practices. Now, in terms of the impact on the patient, certainly it goes well beyond pain. Activity, walking, energy, sleep, mood, and just overall enjoyment of life, often associated with depression and anxiety. So what are some of the goals of treatment? Well, if you can find an underlying condition, like diabetes, like HIV, deal with that, and often that can help the neuropathy. Often that doesn't do enough, and the pain persists. And so we're looking to reduce pain, improving quality of life, physical functioning, and emotional functioning. What are some of the options we have for treatment? Well, I'll say a few words about drugs, oral therapy, physical therapy. You'll hear a little bit later from Shana about complementary and alternative medicine, and Jessica will touch on this as well, psychological support. Now, what about the continuum of pain treatment? From non-medication approaches like psychological and physical therapies, topicals for the skin, oral therapy, and even interventional things like surgery or pumps. Now, just because something's more invasive doesn't mean it works better. In fact, many of these interventional approaches don't have a lot of good research underlying their benefits. Now, I'm going to say just a quick word about treatment, because to do it justice would again take a whole talk. But let me just introduce the topic, and certainly we can go into more detail on this a bit later. What about the oral medications we have for neuropathic pain? Well, these are the classes of drugs with efficacy or benefit shown in the so-called classical research study. We call it a randomized, double-blind, placebo-controlled study. Some of you may have been in them. And these are the main categories. We have anticonvulsants, seizure medications for epilepsy, like gabapentin, known as Neurontin, pregabalin, or Lyrica. I imagine many of you have tried these drugs. Antidepressants, amitriptyline or Elavil, duloxetine or Cymbalta. And it's very interesting. Why antidepressants? Well, I'll say a word about that in a moment. And then the interesting and somewhat controversial use of opioids or narcotics, morphine, oxycodone, Percocets, Vicodin. And there's a huge controversy in the medical world right now about what is the place here, and I believe Jessica will talk more about this a little bit later. So, how do we determine if these drugs really work? Well, the classic approach and what the FDA requires for approval is the so-called placebo-controlled study. Now, here is a little bit of a tongue-in-cheek approach to placebo, with it saying, of course, parachute design and testing should always be done with the utmost scientific rigor and diligence. And this fellow is using a placebo parachute, and I imagine you'll figure out what happens to him. Do we need placebo for every intervention? Well, maybe not, but we're often forced to do it because of the regulatory authorities. Now, as of today, these would have been approved by the FDA for various types of neuropathic pain. The lidocaine patch, but only for shingles pain, postherpetic neuralgia. Gabapentin for postherpetic neuralgia. That's the only approval, interestingly enough, even though we use it for everything. Carbamazepine or Tegretol, trigeminal neuralgia, type of facial pain. Duloxetine or Cymbalta for diabetic neuropathy. Pregabalin or Lyrica for a couple of other forms. The high concentration capsaicin patch from the hot chili pepper, something we've studied over the years. And tapentadol, which is an interesting dual acting agent for diabetes. Now, I'm going to skip over opioids because Jessica will do it more justice later. A word about combination therapy. I imagine for many of you, your doc said, here's a pill, take it, and let's see if your neuropathy feels better. And you come back, you go to the biggest dose you can take, or maybe you have side effects, and it's not enough. And so what do? They may stop that drug and try another, stop that and try another. And that's called monotherapy, one drug. Well, there's some information today suggesting that using drugs together, so-called combination therapy, may be rational and effective. Now, what are some of the advantages? Well, maybe you can use lower doses of each drug and reduce side effects, and maybe you'll have more benefit, whether it be additive or what's called synergistic, drugs working together in order to improve the benefit. Now, there are some problems you need to be careful with. You may get now more side effects from both drugs. You may have interactions of the drugs. It increases the complexity. And if there's a side effect, there's a drug 1 or drug 2. So this has to be done cautiously and rationally. But most of us in the field now do this on a regular basis because by the time they come to see myself or Jessica or Shanna or Mary Catherine, they've already seen 10 other doctors and none of them have figured out what to do. And now we're at a higher level of challenge to make things better. A word about the skin. Now, one of the problems of oral drugs is the drug circulates through the body and gives you side effects, drowsiness, confusion, falls, or any of the above. So what about putting the drug directly on the skin to affect pain? Well, here are a couple of examples. The lidocaine patch, some of you may be familiar with. In this case, this patient had shingles with a lot of pain on the skin, and the patch can be effective there. And then capsaicin, which is the drug of the hot chili pepper, which you can get over the counter in any pharmacy, very low concentration, or this high concentration patch, where a single application for 30 minutes in the clinic can lead to 3 months of pain relief. And this is what this high concentration capsaicin patch looks like. You map out the area of skin. You then pre-medicate with a form of EMLA, lidocaine cream. Then the patch is carefully applied and a sock is put on for 30 minutes. And that can affect pain for 3 months. And we've shown benefit in HIV neuropathy, in diabetic neuropathy, and unfortunately, the only approval in the US is shingles pain. In Europe, it's approved for all neuropathic pain. But this is hard drug to access because insurers often don't cover it off-label. So finally, to take this home, let me finish just a couple of final points. So patients who go and come to their primary care physician, one, diagnosis is critical. It's not just, oh, you've got pain in the feet, you've got neuropathy, bye-bye. We need to do more than that. Diagnostic testing, often best done by a specialist if you have access. Cause-specific treatment, diabetes, HIV, chemotherapy, whatever the cause is, deal with that first. That can go a long way. Lifestyle modification as possible. And then finally, pain control that we're focusing on today. Some concluding points. Neuropathic pain is common, major cause of pain and suffering. Pain is underdiagnosed and undertreated. A rational, mechanism-based approach to pain treatment may go a long way to improving quality of life. This is not a one-time visit. Patients that we follow often become lifelong relationships. I've been here in Mount Sinai going on 35 years, and I have patients that I followed for almost that entire time. And finally, goal setting. One of the first things I tell a patient with neuropathic pain is don't expect that the pain is going to be gone. It's going to disappear down to zero. That expectation, we try, but often don't get all the way to zero. We may get a 9 out of 10 pain down to a 5 or a 4 or a 3 out of 10. That's pretty good. But it's not zero. But the patient needs to hopefully learn to function with the residual pain they have. And the final challenge is, how do we balance the hardwired rigors of evidence-based medicine, the research studies that we do that we're mandated to do, certainly by the FDA, with clinical judgment, serendipity, creativity, and empathy? That is, how do we be both researchers and clinicians? And sometimes that creates a challenge. Well, I'm not sure, but we certainly will keep trying. And finally, my last slide to acknowledge my colleagues, many of whom are here today, as well as what our ultimately goal is, turning this gargoyle into what my now 14-year-old son looked like many years ago when he rarely, I don't see him smile very much anymore. 14-year-old boys don't smile a lot, but when he was a baby, he did. So with that, I will conclude my talk, and I know that there are probably questions in the audience, but what I'll ask you to do is hold them for the moment, as Lindsay mentioned, and then following the next talk by Jessica, we will then move into a question and answer. So you may want to jot your questions down or keep them in your head, and we'll come back to them next. So with that, I'm going to move to Jessica Robinson-Papp, who, as you heard earlier, is a neurologist and one of our cherished colleagues here in our department. Jessica is both a consummate clinician, neuropathy expert, and researcher. In her career, Jessica is focused on a number of areas, including HIV and AIDS and the neurologic complications, including being the medical director of the Manhattan HIV Brain Bank, working with Susan Morgello. Jessica has received numerous grants from the NIH. One of her areas of interest is autonomic function, the so-called small nerve fibers. And Jessica will now take on the next talk to discuss issues relating to opioids and medical marijuana. So thank you very much.
Thank you for that wonderful talk, David. David alluded to a little while ago that there is some kind of a flu bug going through our team, so if I talk or lose my voice or start coughing, please excuse me. I have my water up here. I think we're gonna make our way through it. Anyway, as he mentioned, my name is Jessica Robinson-Papp. I'm a neurologist. I have special interest in neuropathy and neuropathic pain. And one of my areas of research that we're focusing on now is the use of prescription opioids and when and where they are appropriate. So I'm going to be talking to you today specifically about the use of opioids and medical marijuana in the treatment of neuropathic pain. So here's the outline for the talk today. First, we'll talk about efficacy. What is the data that these agents are helpful for neuropathic pain? And how does it compare to the evidence for other treatments, some of the things that Dr. Simpson mentioned, like our antidepressants and our antiepileptics. And then after talking about the efficacy, we'll talk about what are the risks, how large are the risks. Many of us are concerned about this as doctors and as patients. And then finally, I'll talk about some of the regulatory issues, the laws and the regulations that doctors are asked to follow, and how they apply to you as a patient. So, first about efficacy. So first I'll just mention some limitations about neuropathic pain research in general. So the first one is that most studies are very short. Dr. Simpson alluded to FDA approval for drugs. So usually the FDA will require a 12-week study to determine that a medication is efficacious for neuropathic pain. But that's not really how we live our lives, right? 12 weeks is a very short period of time, and neuropathic pain can be something that goes on for years or a lifetime. And so really our data tend to be limited to very short periods of time. So sometimes people will say, well, we don't have evidence that opioids are effective long-term. The reality is we don't have evidence that anything is effective long-term. So we have to balance those two things. We don't have a lot of research about combinations of medications either. So when a drug company is trying to prove that their drug works, they test that drug in isolation. When we get out into the office and we're trying to treat a patient, that patient comes in on a lot of different medications, and oftentimes we have to combine different pain medications to help them feel better. And as soon as we do that, we're sort of off in this area of art and out of the realm of pure science, because we don't really know on a large level how those two medications work together. In these clinical trials, oftentimes patients who are more medically complicated are excluded. So people who have a lot of other medical conditions. For example, if you have a diabetic neuropathy and you're in a diabetic neuropathy trial, oftentimes if you have another kind of pain, they don't want you in the trial, right? If you have low back pain or sciatica, or if you also have had chemotherapy, then you're excluded from the trial. So the trials look at a very highly selected patient population that might not be representative of everyone. And the final challenge is that effectiveness overall is modest in these trials, and placebo effects can be large. So for a symptom like pain, which has to be reported by the person and can't be objectively measured, the effect of placebo tends to be quite large in a trial. So if we give a medication that doesn't have any kind of active quality in and of itself, the placebo, the so-called sugar pill, people will sometimes get 30% better from that. And it's not that those patients are lying or that they're fooling themselves. They have very active effects on the brain if you believe a treatment is going to help you. And that's something that's important to think about in clinical pain trials. So sometimes we say the best medications done in these clinical trial settings make about 50% of the patients about 50% better. It's something, but it's not perfect. So I'm going to start by talking about opioids, and just a couple of definitions that are probably obvious, but just to make sure that we're all on the same page. Opioids refer to a lot of different substances, and I think of them in sort of three main buckets. One are the prescription opioid painkillers. Those are things like oxycodone, morphine, Vicodin, Dilaudid. The other ones are street drugs, which overlap with the prescription drugs, but also include things that are not used medically, like heroin, and now you may hear about these illicit fentanyls that are on the street, these very strong synthetic opioids. And then opioids are also used for addiction treatment. So when somebody has an opioid use disorder, they may get methadone or buprenorphine to treat that addiction. So what's the evidence that opioids are effective for neuropathic pain? So this is an article that was published in Lancet Neurology in 2015, and this is a meta-analysis, which means that these authors went out into the literature and found all of the different research articles that they could find about different treatments for neuropathic pain, and then they combined the data into a large analysis to try to get an overview of all of the literature about efficacy. And they looked at a lot of different agents, and you can see them here in the table. They looked at the tricyclic antidepressants. Those are things like nortriptyline and amitriptyline, also known as Elavil. They looked at the SNRIs, these are the antidepressants like duloxetine, the gabapentinoids, pregabalin, gabapentin, tramadol, which is a weak opioid, strong opioids, the capsaicin patch, and then also Botox. And there are a number of different ways to compare across studies for efficacy, but what they did in this study is they looked at a statistic called number needed to treat. And what that means is, if I give this medication to a lot of different people, how many people do I have to give it to before one person will have a very good response to that medication? So if the number needed to treat is 4, it means if I give this medication to 4 people, 1 will have a good response to it. And so you can see what the numbers needed to treat here are. So lower is better in this case, right? You want to treat fewer people to get a good effect. And actually the thing that had the strongest effect were the tricyclic antidepressants, followed after that by the strong opioids, followed by tramadol, which is a weak opioid. So it would be disingenuous to say that opioids are not effective for neuropathic pain. They seem to be really as effective as anything else, and probably more so than some of our other agents. There's also literature about synergy. So I said that there's not a lot of research about combinations of agents, but there is some. And here's a very classic paper that a lot of us refer to, where the researchers were looking at a combination of morphine and gabapentin, and then comparing that to morphine alone, gabapentin alone, and then a placebo medication. And what the researchers found here is that here's the amount of pain that the people had at baseline without any treatment at all. It got a little bit better with the placebo, and a little bit better with gabapentin, and a little bit better with morphine, and then they did the best with the 2 together. And so in this study, at least, we have some evidence that 2 medications, one of which is an opioid, was helpful for these patients. So what about cannabinoids? Again, we can kind of think of them in 3 different general areas. One are the synthetic cannabinoids. So there are drugs that are made by a pharmaceutical company in a factory that are modeled off of natural cannabinoids that are used in medicine, and we've had those for a while. Those are medications like dronabinol and nabilone. They're typically indicated for gastrointestinal kind of symptoms, so people will use them for in cancer patients who have nausea and vomiting from their chemotherapy, or also in cancer when people have excessive weight loss. They're good for stimulating appetite. So those are what these medications tend to be used for. They don't tend to be used much for pain, although there's some research that they might be effective. There is also recreational marijuana. So this is the marijuana that looks like a plant. They're leaves. They're used, recreationally. And this is something that is legal in some states, but not here in New York State. And then there's medical marijuana. And medical marijuana is not one specific thing and is actually quite confusing and varies depending on the state that you're in. So, for example, medical marijuana in California looks a lot different than medical marijuana in New York State, and what qualifies as medical marijuana might be different. So there, for example, they have actual marijuana leaves that you can get and use however you like, either by smoking it or putting it in food or other kinds of applications of it. And that's medical marijuana in California, whereas here in New York, it's a much more tightly regulated product, which I'll show you in a little bit. So marijuana has a lot of different ingredients in it. So when it's a synthetic cannabinoid that's made by a pharmaceutical company, it just has one thing in it, and that's typically THC. But when it's a natural product, or the leaf itself, it has a lot of different compounds in it. And over 400 different compounds have been identified already. About 60 of them are what we call cannabinoids. And there are 2 major cannabinoids that we know the most about and that we have the most research on, which you may have heard of, and those are THC and CBD. The products that we have here in New York State have both THC and CBD in them, and those 2 cannabinoids have different effects, some of which have good research behind them and some of which are a little bit more like lore about what people feel one is better for than the other, and I'll be a little more specific about which ones have stronger data. So THC is the one that has the psychoactive effects. It's the one that makes people feel sleepy or high. It also probably has the stronger effect on general kinds of pain, so not just neuropathic pain, but maybe pain from arthritis or musculoskeletal type pains. It's a good appetite stimulant, and it's good for nausea and vomiting, and because it has psychoactive properties, it's good for sleep. CBD has no psychoactive properties in and of itself, so people can take CBD and then go about their regular activities. They can work, they can drive. It doesn't make people high or sleepy on its own in isolation. And it can be good for neuropathic pain, and so this can be a good choice for people who just have neuropathy pain and don't want to have any kind of cognitive side effects from a medication. It also has pretty good use as an anxiolytic, so for anxiety. And then some of the best new data out about CBD is in epilepsy. So there's a new CBD product that was approved by the FDA, I think just a couple of months ago, that will be used for refractory forms of epilepsy. So that's another big use of CBD. So you may hear about something called the entourage effect, and this is a concept that is popular in the medical marijuana field. And it's the idea that some of those other 400 compounds are important in the way that medical marijuana works. And people, particularly who are promoting medical marijuana and have companies selling medical marijuana, are quite invested in this idea. We don't have data that it's not true, but we don't have a lot of data that it is true either. It doesn't matter much in New York State because we don't have anything that looks green at all. We have some very standardized formulations here. But if you went to a state that was a little bit looser in their regulations, like California, you would see different kinds of medical marijuana marketed for different reasons. Like this one is good for this kind of disorder. This one is good for that because it has more of this entourage chemical or more of that. And this falls into what I referred to before as sort of lore. There's not like a lot of hard evidence that any of this is effective, but I give it to you just because it's out there. So what is the data about the efficacy of medical marijuana for different kinds of medical problems? And so there's actually a very comprehensive review that was put out by the National Academy of Science and Medicine back in 2017 that looked at medical marijuana for every kind of medical indication, not just neurologic ones. It's a very long monograph. It's actually available online if you wanted to read it. But this is sort of their 4 summary bullets of like several hundred pages of text. And this is what it says. In adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. So they help people to not feel nauseous and throw up. In adults with chronic pain, patients treated with cannabis or cannabinoids are more likely to experience clinically significant reduction in pain symptoms. So they do have some efficacy in pain. And then the third indication is multiple sclerosis-related spasticity. So patients with multiple sclerosis get a lot of stiffness in their muscles and they have trouble sort of straightening out their limbs and moving, and medical marijuana can be helpful for that. The fourth bullet is a caveat that for these conditions, in general, the effects are modest, and then for all other conditions, the data is not very good. Now this review was published before the large clinical trials were done in epilepsy, so I think that now this probably would be updated to include epilepsy as having good data, because that data is pretty strong. So what about cannabis specifically in neuropathy? Probably the kind of neuropathy for which it was studied the most is HIV-associated neuropathy. And doing studies with medical cannabis in the US is really hard. If you want to do a study looking at medical marijuana itself, you have to get it from the government. There's one particular purveyor of the medical marijuana. There's a lot of sort of logistical hurdles to go through. And so these studies are sparse, unfortunately, because of these hurdles. So because of that, the studies that we do have tend to be even shorter than the ones that are for pharmaceutical agents, because you can't give the patients the marijuana and tell them to go home with it. You have to observe them while they're taking it. That being said, these are 2 studies that looked at patients with painful neuropathy, and they were randomized to receive either cannabis cigarettes or placebo cigarettes. So they have the same kinds of cigarettes, but they take the THC and the CBD out of them, so they like look the same but are different. And in this case, they looked at people who smoked it 3 times a day for 5 days, and they looked at just acute pain, so the pain that they were having in that moment while they were using the medication, and they found that it was efficacious in reducing the pain. So for example, in this study by Abrams, the first smoked cannabis reduced the patient's chronic pain by 72% versus 15% in the placebo group. So outside of the US, a product called nabiximols has been approved in a number of different countries, including Canada and different places in Europe. And this is a natural product. It's derived from actual marijuana, but in a very pharmaceutically controlled manner so that each dose is the same and goes through a sort of rigorous process. And so there's a little more data that's more long-term using nabiximols because we're in areas where this is approved and you can give it to the patient, they can go home and take it on their own. And so, for example, this study from 2007, it was a larger study. There were 125 patients with neuropathic pain, and this is different kinds of neuropathic pain, not just HIV. And it was efficacious in helping the patients with their pain, and they went out to 52 weeks in an open label extension. So an open label extension means that after you're in the randomized part where you might get placebo, that part ends and then everybody's able to get the actual drug to see how effective it is. And then there's another study that had a similar outcome in 2014 that was even larger with 239 patients. So this provides some evidence that these combinations of THC and CBD that come from the natural plant are efficacious in neuropathic pain. But unfortunately, this particular agent is not something that we have access to in the US. So we have some data that these treatments work, but how risky are they? That's always the concern with the controlled substances. And that's not an easy question to answer. So we've all heard a lot about the opioid epidemic. We all know that opioids are highly addictive. And the main problem with them, other than being highly addictive, is that they are lethal in overdose. So if you take too much of an opioid, your respiratory drive will be suppressed, you'll stop breathing, and that's potentially lethal. But what is the relationship between prescription opioids, so the ones that your doctor might give you, and the current opioid epidemic? Well, in general, we know that the opioid epidemic is far from over. In fact, it's getting worse year after year. So in 2016, we had 42,000 deaths from opioids in general, and 70,000 deaths the year after, so not going in the right direction yet. Currently, 60% of opioid-related deaths are due to illicit street drugs, so that's heroin and this manufactured fentanyl, but that still means that 40% are due to the prescription drugs. And even today, 2016, which is the last year that we have data, about 20% of Americans overall received at least one prescription for opioids in that year, which is really tremendous if you think about it. It's a lot of people. So it's true that people who end up being addicted to illegal street opioids usually started with a prescription opioid. However, it's also true that it usually wasn't their medication. So where did they get it from? So they got it from usually a family member or a friend, and sometimes, and most of the time it wasn't like a selling situation. It was a family member or a friend who had their own prescription who was trying to be helpful to that person. Or they were unaware and the person took it from them without their knowledge. So one of the things when we do use opioids and prescribe them to patients is that we have to be aware of the safety of the community and the surrounding people, which is not something that we're always thinking of as doctors. We see the person in front of us and we're focused on our patient, but we don't often think about the people around them. So it's something that we have to think about. But what about you as the patient? What is the risk to you if you take a prescription opioid? So I'll say that the methodology of figuring this out is really tricky because if we prescribe a medication with addictive properties to someone, and then we're trying to figure out what happens to that person, our choices are to ask them, which is imperfect, because if people develop addiction, they may not be honest with us. And the other options are not perfect either. We can't follow them around all day and figure out what they do. We don't usually get approval for studies like that. So it's imperfect, I'll say that. But the best data that we have is that probably about 1 in 10 patients who are prescribed opioids for chronic pain, so not just an opioid because you had your tooth out, but sort of a more chronic prescription, about 1 in 10 will have a problem with addiction. So 9 in 10 won't. 90% of people will probably be okay. And a 10% side effect rate is not out of the ordinary with some medications, but it's just the severity of that side effect that's so very worrisome. And how do we define addiction? So there's lots of different sort of technical ways in which people define addiction. The way that I think is the easiest to think about is loss of control over the substance. So continued use of the substance despite harm, characterized by impaired control, compulsive use, and craving. Now, are there people who are at more risk from prescription opioids? Yes. It's probably intuitive that people who've had problems with substances in the past are at greater risk for developing an opioid use disorder if they're exposed to a prescription opioid, particularly if their drug of choice in the past was an opioid. We think that that risk is probably 2 to 4 times greater. So if you think about your baseline risk and overall risk being 1 in 10, when you get into somebody who had a previous opioid problem, then your risk probably goes somewhere to 30 to 40%. So now a pretty high level of risk. So what about marijuana? Marijuana is an addictive substance, but much less so, and it is not lethal in overdose. It's very hard to kill yourself by overdosing from marijuana. And so that in and of itself makes it a lot safer. And there is good evidence. So what are the risks of marijuana? There's evidence for an association between cannabis use and all of these sort of different side effects. Chronic cough is only important if it's a smoked cannabis product, which is not everything. There are some things that are obvious, like some impairments in learning and attention and memory with acute use, again, of THC. That doesn't apply to the CBD. There's an association with other drugs of abuse. Association does not mean causality, right? So there's this talk of marijuana as a gateway drug, right? If people, or particularly young people, adolescents, start with marijuana, are they more likely to go on to use other drugs? Yes, but it doesn't mean that the marijuana caused it, because you could also say that people who are more likely to go on to use other drugs are probably people who are more likely to use marijuana in the first place. So all of these risks are associational, not clearly causal. There's some concern with people who have pre-existing psychiatric conditions. So we don't advise medical marijuana for people with psychotic disorders, because that can certainly make it worse. But in somebody with no psychiatric history, it's not going to cause a psychotic disorder. It's not recommended in pregnancy because of lower birth weight. And then we also are cautious with people who have pre-existing bipolar disorder or serious untreated major depression, because it can make those things worse. So in thinking about risk, this is just an interesting slide which I'll present to you, which looks at what happened to opioid overdose rates in states that legalized cannabis. And the sort of take home of this data is that when a particular state legalized some form of medical marijuana, it seemed that in that same time frame, opioid overdose rates went down. So again, we don't know that that was the cause of it, but it's just sort of an interesting temporal association that suggests that perhaps people are using medical cannabis instead of the opioids and then avoiding some bad outcomes. I'm going to just quickly talk about the medical and regulatory stuff. A few things that are important. Opioid supply is at risk at the federal level. Medicare is constantly making rules about how we can dispense opioids, what we can prescribe, and how much. We were really worried that for next year they were going to put a cap, like just a solid cap, that patients cannot get more than X milligrams, which is a really bad idea in my opinion, because there are patients out there who have been on long-term high-dose chronic opioids, and you can't just take them off. Like, it has to be a very slow and well-supported process, and for Medicare to just say, nope, you're done, is a really bad idea. So they didn't do that, so that's great. They actually did some really reasonable things, which were, if there's a beneficiary that they think is at risk, and there's some definitions for that, then they're giving more resources to that person, which is very nice. They're saying, okay, you're going to have some care coordination. Maybe we're going to restrict you to having one doctor and one pharmacy to your opioids, which is a good idea anyway. And they made a law saying that if it's your first opioid prescription, you should only get a 7-day supply. And so those are for people who have an acute condition like, a tooth being pulled or a surgery, just to have less opioids in the community. There's also a whole set of guidelines that were put out by the Centers for Disease Control, advising doctors how to prescribe in a more conservative, safety-oriented manner. And I can talk more about that during the break if people are interested. But this is really a helpful guide for doctors. And so if you see your doctor doing different things with opioids, some of that may be because of the guidelines that we're being told to adhere to. And what about marijuana? What are the laws? I'm going to focus on just telling you about what's available in New York State and what our laws are here. So medical marijuana was legalized in New York State in 2014 by the Compassionate Care Act. It stipulates certain conditions for which a doctor may recommend medical marijuana. It's only legal in a pharmaceutical form. You will see nothing green, and it is not legal to smoke it, and recreational use is not legal as well. And providers can become certified to recommend medical marijuana for their patients relatively easily. Doctors can do it, also DOs, PAs, nurse practitioners can all do it. You have to go online and do a 4-hour training, and that's pretty much it. The formulations that are available here in New York State are 3 different kinds, which I'll go through on the next slide briefly. But before I do, I'll just touch on the fact that you may, if you were curious to look, find all sorts of weird cannabinoid products online. Here are some that I found just by Googling, and I put them here for your amusement. This is a cream. Here are some gummies. Here's water infused with CBD, and then here's some drops that you can put in your mouth. These are technically legal, and the reason for that is that industrial hemp is a form of cannabis. It's like a plant that we grow to make other things. Like you can make rope out of it and fabric, and you might see in Whole Foods like jars of hemp milk. It's supposed to have nutritional properties, but it does have very, very tiny amounts of CBD in it. So if you take enough hemp and put it through a process, you can get some CBD out of it. And so that's what these products are. They're not regulated as medication. They're regulated as things like cosmetics. And so Lord knows what's in them. And we don't generally advise that people use them, but I try to make my patients aware that they're not a regulated product. So it's sort of a buyer beware situation. These are the conditions for which you can get medical marijuana in New York State. You have to have one from column A and one from column B, a severe debilitating condition, and an associated condition or symptom. And so neuropathy counts as a severe debilitating condition, and severe or chronic pain counts as a symptom. So if you have neuropathy and chronic pain, then you can have medical marijuana in New York State. These are the routes of administration which are approved in New York State. So there are 3. You can get it as a vapor. So that comes with like a little vaporizer pen, and it's a cartridge. It goes into the pen, and then you inhale the vapor. That is good for acute pain. So it's quick in onset, quick in offset. Then there's a sublingual tincture. So this is like a little dropper of an oil that can go under the tongue. This is sort of a medium duration. It's a little slower in onset, but lasts a little bit longer. And then there are pills available as well that are sort of long duration, but they don't come on very quickly either. And then in each of these 3 categories, you can choose to have something that is either high in THC, high in CBD, or a balanced combination. So I think that is the end of my slides. Just to summarize, we have some evidence that there's benefit of both opioids and cannabinoids in the treatment of neuropathic pain, but because of safety concerns, they're not considered first-line agents by most experts and in clinical guidelines, which do recommend that other medications with lower addiction risk should be tried first. However, when those other lower risk medications are insufficient, it may be reasonable to think about opioids and cannabinoids in carefully selected patients with whom the provider has a long and ongoing relationship. Opioids do carry a significant risk, but can be used safely in many people. And cannabinoids are probably safer, but the formulations vary a lot state by state. And so the exact formulation that we have in New York State, we do not have research on that exact formulation. We have to extrapolate from other formulations of cannabinoids. So that's also a caveat. And I will stop there. Thank you.
Great. Thank you so much. I'll invite Dr. Simpson to join me. We'll have about 30 minutes or so of question and answers. I have a couple of handheld mics that we'll be able to pass around so that if you have a question, just raise your hand. Myself and my colleague Nancy in the room will try to get to you quickly. And then I'll just ask the 2 of you to repeat the questions one more time just in case people can't hear, and then answer. Sounds good?
Sure.
Okay, great. Thank you. So any questions?
Okay, so let's work our way from left to right.
Got a mic over here.
Oh, I'm sorry. There's a mic. Okay, please. Yes, sir.
Is there any benefit for implantation of a TENS unit in the spine? Any studies on that?
Yeah, well, you're talking about devices. You mentioned TENS and in the spine, so let me separate those and turn it over to Jessica as well for some comments. So TENS, or transcutaneous electrical nerve stimulation, is a device that has been in use for many years, and it's meant to contribute to pain relief. It's often used by pain physicians, rehabilitation physicians. In neurology, I don't think we use it quite as much as some other fields. It has an interesting theory behind it called the gating theory. And what does that mean? And in fact, a Nobel Prize was awarded based on the gating theory. Let's say you put your finger on a burning stove. What's your first reaction? Shake the hand. And what is the idea behind that is that by shaking the hand and providing other sensory stimuli to the brain, it may provide gating so the pain stimulus is reduced. That's the theory. TENS is based on a similar theory. By providing electrical stimulation to, let's say, the leg, if you have pain in the leg, that may in some fashion reduce pain. The data for TENS, at least to my knowledge, I haven't looked at this for a while, I would say it's probably modest to weak. I tend not to prescribe it to people with neuropathic pain, but others might. Now, as far as the implantation approach, there is an approach in which certain types of severe refractory pain, including neuropathic pain, that hasn't responded to the oral medicines and other approaches we talked about, one can, in fact, implant a spinal cord stimulator. And that's done by a surgeon. It's left in chronically. And again, the data is mixed, but for some individuals, that approach can provide benefit. But remember, it's surgery, and you now have an implanted device within your body. Jessica, any comments on either of these?
Yeah. I think my approach with patients is to always weigh how strong is the evidence that something works compared to what is the potential risk. So if people have a TENS unit that they're using superficially and that helps them for pain, great. I don't really, in a practical sense, I don't care why it works or how it works. If it's working for that person, great. Whenever there's an interventional procedure, though, I am very nervous about people doing that because I don't think that the data is good. And then there are risks of, infection and it not working, and it is a surgical procedure. So that I tend to be very cautious about. I think the data for TENS is maybe a little bit better with musculoskeletal kind of chronic pain of that nature. But still, I'm pretty cautious with people.
Hi, thank you so much. I was wondering about B12 deficiency or magnesium deficiency, and could that contribute to peripheral neuropathy?
Mm-hmm.
I have diabetes and I have peripheral neuropathy in my feet, and I'm older. I don't know if I'm even absorbing the B12 that I sometimes take. I don't know.
Yeah. So B12 is a well-known cause of peripheral neuropathy. It can also cause a lot of different kinds of neurologic disorders. It can be involved in memory impairment and problems with the spinal cord. So when we encounter a person with neuropathy, even if they're already known to have diabetes, we always test them for B12. And you can test for B12 itself and then some related tests that can be abnormal in the blood that can detect a subtle B12 deficiency. B12 is very hard to absorb through the stomach. It's just not very well absorbed. So even if you take 1,000 micrograms per day, which is what most of the vitamins have, sometimes it doesn't absorb well. And in patients who don't absorb well, then we can just give them intramuscular shots of it. But it would be important to get the level checked before you go ahead and do that, because you also don't want to be overdosing on vitamins. Some B vitamins, if you take too much, can actually make your neuropathy feel worse. So it would be important to get checked for. Sure.
Hi. I have, thank you for those great presentations. I have idiopathic small fiber neuropathy. And I was curious about two things. One, the prevalence slide. I was wondering if there's what the prevalence is of that, because I haven't been able to find a good number. And then I was curious in terms of treatments. With that, I also have autonomic neuropathy and trying to balance treatments that are effective for pain without increasing the exhaustion, lightheadedness, dizziness of autonomic.
That's a really good question. So I'll speak to the second part, and then I'll let David maybe talk about prevalence, because that was his slide. So just for the group, the question was about, that I'm going to answer, is about autonomic neuropathy. So we didn't talk about that much today, but what that means is that when the kind of neuropathy that we mostly think about is the nerves subserving motor and sensory function in our hands and feet, right? Like, so numbness or tingling or pain or weakness in the body, but there are actually nerves all throughout the body, doing a lot of different things that we don't think about every day. So nerves control our blood pressure. So the fact that we don't all pass out when we stand up is because our autonomic nerves are controlling our blood pressure. It controls the way our gut moves. So the fact that food can move from our stomach into our intestines is dependent on the autonomic nerves. Things like immune function, sweating, lots of different things are controlled by autonomic nerves. And so autonomic nerves are smaller fiber nerves. And so sometimes when you hear small fiber neuropathy, that's neuropathy that affects the smaller nerves more than the larger ones. And those people tend to have a burning kind of painful syndrome in the feet and or hands, and then also involvement of autonomic nerves. So one of the main symptoms of autonomic neuropathy can be fatigue and dizziness on standing, because your blood pressure can tend to drop. And a lot of the medications that we use to treat neuropathic pain have what we call anticholinergic side effects, right? So the side effects that actually make autonomic function worse. So that it's very hard to balance. And in treating symptoms of autonomic neuropathy, it often depends on what symptom is the worst. I tend to, so the things that have more anticholinergic side effects are the antidepressants, particularly the older ones, like the tricyclics have a lot of anticholinergic side effects, and those would not be a great choice for somebody with autonomic neuropathy. The SNRIs, however, can be better tolerated, particularly duloxetine, and I'm going to say Savella because I always say the generic, and it sounds funny when I say it. Those tend to boost blood pressure a little bit. So people whose blood pressure kind of runs a little bit on the low side, that can be helpful for that. Particularly if you don't have the problem of supine hypertension. So some people with autonomic neuropathy get low blood pressure when they stand up, but then overly dangerously high blood pressure when they lie down. So that's something to be aware of. Also, the gabapentinoids can promote some fluid retention. That's a worrisome side effect. In some people, it can make for swelling in the legs. But for people with autonomic neuropathy, a little bit of fluid retention can be good because it can kind of help you hold on to blood volume and make the dizziness less. But it's definitely a problem. The topicals, sometimes if they're helpful, that can be a good option. And then also, if you do have autonomic neuropathy, one thing that I tell my patients is that we're just really careful about everything that they take. Because sometimes they may take, like I had a patient he gets really bad allergies. It makes him miserable. Like he's stuffy the whole spring. And he had started taking over-the-counter Zyrtec. And he was like passing out all the time. And we're like, what is going on? Why are you so bad all the time? Your blood pressure's all over the place. And he didn't even think to tell me because it's an over-the-counter kind of medication. And finally, we figured out that that's what it was. And we were able to take that away, and it got better. Some of the muscle relaxants are like that too. Like tizanidine has a lot of anticholinergic side effects. So it's kind of, it's a bit of a balancing act and, figuring out which are the best. So prevalence of idiopathic small fiber neuropathy.
Right. Well, let me separate out that question into two parts. One is idiopathic and one is small fiber, because they're not exactly the same thing. What does idiopathic mean? That's the medical lingo for we don't know, okay?
It makes us sound smart.
Tell patient, idiopathic, what the heck is that? We don't know. And by the way, the older I get, and I'm getting there, the more I tell patients, I don't know, because it takes a certain amount of confidence to say that. If you have for a person with neuropathy and go to an academic center, to a neuropathy specialist, They've done all the tests that they can think of, the blood work, look for diabetes and B12 deficiency, and even genetic testing sometimes. And at the end of the day, all the tests are negative. They're all normal. What's the cause of neuropathy? We don't know. And that's idiopathic. And how common is that? Again, the numbers are hard to come by because they vary a bit from study to study. But one can approximate anywhere from about a quarter to a third of patients with neuropathy don't have a cause identified, idiopathic. So if a doc tells you, we don't know the cause, don't just think, why, this guy is pretty stupid or this doc doesn't know what they're doing. It may be that that's in fact the best we can do. Now this is a moving target because as we go forward and learn more about neuropathy, part of what we're doing in the Foundation cohort study, we're learning new things, including genes. And more genes are being discovered that underlie neuropathy, particularly now with whole exome sequence testing and all the genetic things available. Now, small fiber neuropathy is, as Jessica just mentioned, the small nerve fibers affected, burning, pain, tingling, pins and needles, autonomic problems. And as far as prevalence of that disorder, I'm not sure, Jessica, there are great numbers on that. And so I would be reluctant to throw out a number, but certainly most neuropathies are mixed, large fiber and small fiber. There are occasional patients with exclusively small fiber with the normal EMG testing. We run into that commonly. The skin biopsy can be very helpful in diagnosing that. And of course, management of pain and, as Jessica mentioned, autonomic symptoms can be very, very important in those folks.
Yeah, I think one of the reasons we don't have the best data about prevalence for that is that skin biopsy is the way that you diagnose it, and it's not done everywhere. And also some patients just choose not to do it. So if the patient has symptoms that are consistent with a small fiber neuropathy, you may just go ahead and say, okay, I'm just going to treat that. Like the skin biopsy might confirm it, but you may not need the confirmation for clinical purposes. So, but I would say in my clinical experience, it's the small minority of patients that have an exclusively small fiber neuropathy.
And by the way, there are no medications approved by the FDA for either idiopathic neuropathy or small fiber neuropathy. And so we use medicines that are proven in other diseases like diabetes and shingles. And frankly, those are about the only two conditions, perhaps trigeminal neuralgia, one other, that are FDA approved. So we end up using what we call off-label medicine, meaning not approved by the FDA, but we extrapolate from other data and from studies like Jessica showed you, the meta-analysis by Finerup, that there are data in the literature, it's just it hasn't gone through the rigors and frankly the many millions and millions of dollars it takes to get these studies through the FDA.
I have two questions. Is the skin biopsy definitive? Is it possible to have a normal skin biopsy and still have small fiber neuropathy? That's number one. And number two is you didn't mention IVIG, infusions, Gamunex, any of that. You didn't mention that. I'm just wondering if you could comment on the efficacy of that as well.
Well, let me let Jessica address the skin biopsy question, and perhaps I'll take on the IVIG.
Yeah. So it certainly is possible to still have small fiber neuropathy and have a normal skin biopsy, but it's not usual. And so that has to do with the idea that most neuropathies are what we call length-dependent neuropathies. And the reason for that is that the cell bodies that are where the nerves start all are up by the spinal cord. And then the nerves have to travel all the way down to your foot or all the way down your hand if they're going to the hands. So the very end parts of those nerves are the ones that are the most vulnerable to damage because they're the furthest away from the source of their nutrients, which is the cell body, right? So our neuropathies are mostly length dependent, and that means that the ends of them they are most affected in the ends of the nerves. So when we do a skin biopsy, we try to get at that by doing 3 different locations at different lengths, right? So down in the lower part of the leg and then higher up. But not all neuropathies are length dependent. Some have a weird kind of more patchy distribution, and that's well described. And when you're taking a skin biopsy, you are by necessity taking a very small piece of skin. So it is possible that if you don't have a sort of uniform distribution of your neuropathy and it's more patchy, that you might miss it on a skin biopsy, but it's sort of the minority of cases that that would be true.
So IVIG, probably a medicine that many of you have heard about, perhaps some of you have even had prescribed for yourselves. What is it? IVIG is intravenous immunoglobulin. It's basically pooled samples of blood product, in this case, plasma, and it's taken from blood donors, purified, and ultimately supplied to individuals with disease. Now, what do we use it for? Well, we use it for so-called autoimmune disorders. That is, disorders in which the body is attacking itself. We call that autoimmune disease or immune-mediated disease. Many of you are familiar with the disorder known as Guillain-Barré syndrome, where people can get rapidly paralyzed even on a respirator within a couple of days, a type of acute neuropathy. Some of you are familiar with CIDP, chronic inflammatory demyelinating polyneuropathy, long-term chronic form of autoimmune neuropathy. And then there are other autoimmune conditions as well, lupus and Sjogren's syndrome. We heard Lou talk about anti-MAG. These are all autoimmune conditions. In that group of disorders, we often use IVIG. That being said, there are some physicians who expand its use more broadly to conditions where there's less data and, frankly, in my opinion, less rationale. So Jessica and I often see patients coming in with idiopathic neuropathies, small fiber neuropathies, saying, I'd like IVIG. I heard it's a miracle drug and it's going to help me. And there are docs who use it. There are some data, but very little. And frankly, one has to be cautious because, as Jessica mentioned, we always need to do a risk-benefit analysis. This is not an innocuous drug. It can cause fluid overload. It can cause clotting and other side effects. It's also very expensive. It needs to be given chronically, often on a monthly basis, potentially for years. And so it's not the kind of thing we throw around like water, but in the proper patient, it can be highly effective. Many of the neuropathies we spoke about today are not necessarily candidates for IVIG, but certainly there are many that are. And if you like, we can talk more about that later. Other questions?
Okay, we've got time for one more question, I think we have back here. And
Yeah, thanks. And thank you both again for those great presentations. And I was very interested to hear Dr. Robinson Pat mention a combination drug treatment, which I've been on forever, and I rarely speak with other PN patients, so I've been on gabapentin for a fairly high dose, and tramadol, fairly low dose, 50 milligrams, 5 times a day, for years. And it's managed my condition very well. But see, how frequently do you use the combination? It must take a while to figure out, is that?
Yeah. So I think so we're specialized specialists. So a lot of the times, by the time people get to us, we don't end up with the easiest people. So the people who just did well with the first thing usually kind of don't make it all the way. So in our practices, multi-therapy is probably more of the rule than the exception. And when I'm meeting a new patient for the first time and I'm trying to manage neuropathic pain or any kind of pain, I need to make it really clear when we're communicating that this is a process of trial and error, and it can be really frustrating for the doctor because I want them to feel better right away, and of course it's frustrating for them. But it's easier if they know that we're going to stick with it together, and we're going to try different things, and we're going to figure out what works. And most of the time, with different combinations and trial and error, we get to something that is a good combination. And it's oftentimes very surprising to me what works and what is tolerable to an individual. And I continue to be surprised year after year. So I have one patient who is incredibly sensitive to medication. She's a very active mom. She's out there during the day. She needs to do deal with kids, do her stuff, and she gets sedated super easily. And so I tried all these different things that I thought were less sedating. And in the end, she ended up on amitriptyline, which is one of the most sedating things. And for her, for whatever reason, she tolerates that very well and can go about her business. And so it's just, everybody is different, unfortunately, and until we have more precision medicine, the combination is definitely an art, and it's about not giving up.
I'll just say one more thing about this, and then I think, Lindsay, we probably should let people take a break. Part of what we do as specialists in this field is, yes, we have knowledge about the latest and greatest medications, and sometimes we have something we can give folks that they haven't tried before, although often they've tried a lot of things. But the other big part of what we do is setting goals and expectations. And what does that mean? Well, I mentioned earlier that if you're going to chase obliteration of pain and keep raising doses, adding new drugs to get someone to zero, that's going to be often a fruitless battle, because often it's impossible and the side effects overwhelm any benefit. The other thing that's very important is, what are the symptoms that one may reasonably expect to improve? And I'll give you an example. I had a patient coming into me taking almost 5 grams, 5,000 milligrams of gabapentin, a sky-high dose, and was sleepy and had swollen legs and had put on a lot of weight, and the medicine was doing all kinds of bad things. And I say, why are you taking so much gabapentin? And the patient told me, because my feet are numb. My feet are numb. Now, what is the problem there? One doesn't necessarily expect, in fact, one wouldn't expect, that gabapentin is going to take the numbness away. Numbness is a negative symptom. It's not comfortable, but it's not pain as we define it. And so if you're chasing the wrong symptom, you're going to be going down a rabbit hole of problems. So again, part of seeing a specialist is not only to get the latest and greatest drugs or clinical trials, but to, one, get a proper diagnosis, and two, to understand that what you are taking is treating the right thing. So with that, Lindsay, we're going to take a little break, right? Do you want to say something? Come on up.
All right, thank you both. Yes, thank you. As everyone's finding their place again, just want to say once again thank you to everyone for coming. During this break over the last 15 minutes, I had a few people ask me about ways that they can help us. So before we get started, as people are starting to trickle back in, there are really 3 easy ways. One is, if you're ever interested in volunteering, helping us spread awareness, helping us fundraise, giving us some ideas, sharing ideas on how to market better, or whatever expertise you might have that you're interested in helping with, we welcome that. So please consider that and reach out to any one of us over the course of the next few days, weeks, or months. We'd be more than happy to chat with you to see how we can get you involved to help better not just the foundation, but you and other patients who are looking for answers. The second one is also for those of you who are located in the New York area, close to Mount Sinai. They are one of our partners for our biobank, our research registry. One of our main missions of the foundation is to advance research to find more answers, better treatments, and hopefully one day cures for your neuropathy. So if you're interested in participating and enrolling into the biobank, feel free to reach out to me, or Dr. Simpson here can also answer many questions, and Mary Catherine, who will be presenting later today. Both are kind of heading up the management side of the project here at Mount Sinai. And then just lastly, how you can help is just being here, coming to our events, spreading the word about our events. sharing information with your family, friends, and neighbors. I think the number one problem we have here at the foundation is we don't know who you are. We don't know who has neuropathy unless you self-identify to us, which is kind of a reactive instead of a proactive way of getting patients into our system to help spread more information and educate them and their family and other healthcare providers about what neuropathy is and what we can do as a team to find answers and make it a little bit more manageable. So just a few ideas. Like I said, I was chatting with a few of you during break and even earlier before the conference, so I thought it would just be a worthwhile way to share how you can help us and support us, not just financially, but if you really are interested in lending a helping hand. With that, I'll actually turn it back over to Dr. Simpson one more time, who's going to introduce our next speaker. Thank you, everyone.
Well, thanks, Lindsay. We're going to continue the theme of patient management. You've heard earlier today about medication, cannabis, opioids, but interestingly, from the audience, there were a lot of questions about non-pharmacologic therapy, that is non-drug therapy. And I'm delighted to introduce Dr. Shanna Patterson within our system of the Mount Sinai Medical Center. Many of you know that Mount Sinai is broadening its tentacles around New York City and beyond, and Beth Israel downtown, St. Luke's Roosevelt have now become part of our system. And one of the real benefits of that type of expansion is to have the opportunity to ally and collaborate with wonderful colleagues such as Shanna, who's based at Mount Sinai West. And there she wears a number of different hats, including the head of the FPA, the faculty practice, the EMG laboratories, very involved in our neurology residency, including coaching residents on wellness. And Shanna also has expertise in peripheral neuropathy. And she's going to share some of those ideas with you today. Shanna?
All right. Good morning. It's really great to see you all here this morning, and it's a pleasure to be here. So we are actually going to be covering two topics in this half-hour session, and I'm going to try to be mindful of the time because I think each of them could easily comprise a whole half hour on its own. The first thing that I'm going to be talking about is really looking at how you communicate with your provider, whether it's your physician, your neurologist, but honestly any medical provider, because there's actually a lot of information that we know that says that patients do better when the communication with their providers is as good as it can be. So we're going to talk about that first, and then the second part of the talk we're going to discuss some of these non-drug oriented other types of ways of managing neuropathy, and in particular pain associated with neuropathy. So part one, optimizing communication with your provider. So there is an awful lot, just to tell you from the physician side, there is an awful lot of focus from the physician side on how physicians communicate with patients. There's a lot of training programs for physicians to figure out how to communicate better with their patients. And this is just a really very scraping the surface barely example of some of these books and programs and different quality improvement sort of initiatives. And you can see in the center box there, it says outcomes of satisfactory communication. And the idea is that we're recognizing more and more, which makes sense when you think about it, that communication isn't just better, in terms of what the patient feels like or what the doctor feels like, but it actually helps the patients do better in terms of their care. Research actually shows that effective communication between patients and providers improves their health outcomes. Why? Well, then this is actually from a number of research studies which are kind of down here, and there's many, many more, but patients participate more actively in their care. Patients are more likely to stick with a treatment plan, probably because the communication has been better to begin with, so it's one that you are in agreement with, for example. Patients are better at managing their health, and there's actually some even like very specific examples with different medical conditions. For example, one study looked at patients who had a specific type of surgery, and they provided more communication and education for some of the patients and found that they experienced less pain after the surgery and required less pain medication. So this is really interesting. This is not all kind of, fluff and feel-good sort of stuff, if you will, but this really makes a very measurable difference in terms of how patients do and their health. These are, again, to give you an idea that people are really doing research on how do doctors best communicate with their patients. These are several research-validated models of how physicians should be communicating with their patients. And there's certain common threads when we look at this. And we know that communication is, of course, a two-way street. So it's the physician who's ideally trying to communicate as best they can with patients, but I think it's great to take a look and say, how can we also look at how patients can be empowered to best communicate with their physicians? So when we look at some of these essences of what are some of these common threads that link together these different models for communication, and these include things like a human-to-human connection, which is not surprising, things like courtesy, respect, developing a good rapport and empathy, and also how can we engage the patient and physician connection throughout the visit, throughout planning the patient's care, in terms of even things like prioritizing or setting the agenda. What's the most important considerations to cover in a specific visit? Treatment decisions, and really empowering the patient in their own care. Now, from a patient's perspective, I think it's important. We always think about, how qualified is my doctor? Maybe where did they go to school, or what is their level of expertise, or do they do research? But really looking at how do I feel like my communication with my doctor is going is also a very important and sometimes perhaps overlooked component in terms of seeing, is your relationship with your doctor a good fit? And if it's really, really not a good fit, in some cases it might be worth even considering switching to look for somebody who you do have a better fit with. And I think we've all talked to family members, friends, and I've certainly talked to patients where you see they've made a switch and you say, well, what happened? And it wasn't that the medication they prescribed was wrong or even the diagnosis was incorrect, but they say, it just wasn't right. And I think that's kind of where, drives to the importance of this. Doctors who have good communication skills often also have patients with better treatment results. And this, I think, gets back to that health outcomes that we talked about a moment ago. So what I'd like to do is what I'm trying to do here today is to look at all of this information that's out there in terms of, which there is some, tips for how patients can best communicate with their doctors, looking at some of the models for what we know in terms of strategies or different points in time where physicians are trying to communicate best with their patients. What I've tried to do is to come up with some advice at different steps along the way through your visit, before your visit, after your visit, for a model of how you can optimize communication with your doctor. And also in a complex medical environment today, communication often goes well beyond just the moments where you're sitting across face to face. It involves things like communicating outside of the space of the visit, and increasingly, especially as physicians are using electronic medical record systems, or maybe working more with nurses or physician's assistants in their offices, how can you use those team members and that technology to your advantage to help improve communication? So let's back up and think a little bit about before the visit. I call this a little bit of like the homework phase. There are some things, and many of you, since you're here, you're probably the most highly motivated subset of patients already, so I'm sure you probably all do these sorts of things. But just to review, some things that can be beneficial to do, especially if you've had a long, detailed, complicated history, or if you have a lot of different concerns, is to take a step back and reflect in advance of the visit. Sort of, what is your agenda? What are your top priorities. There may be a list of 10 things or 15 things that are really bothering you, but if you had to pick the top 3 so that you made sure that you spent the most time on those or prioritized those first, what would those 3 be? So this can be very useful because there's nothing more frustrating, than getting to realizing that your visit's almost out of time and that you haven't made it to that most important thing or this, top second and most important thing. So this can be useful to reflect upon. Making a detailed list of all of the medications that you take and the dosages, again, I'm sure that all of you are probably doing this, but it can be useful, and there are computer systems now which import a lot of different prescription information from pharmacies, but this doesn't necessarily mean that's what you're using at home. And so I think knowing, bringing that information to the doctor is very important for them as well as for you. Writing down questions that you have in advance can be very useful. I think that, we've all had the experience where when you're in the moment and things are moving so quickly, you knew you had questions, but without sort of the written reminder, it can be hard to remember them when the moment comes. Bringing any copies of other records or results that you have can be useful, and a technology tip in advance that can make your life easier. Some offices may have a way for you to either email or complete online some of this information in advance of your visit, which can make things much easier for you. So it can be helpful to reach out and ask the office, do they have a way for you to even get the forms in advance? You can fill out forms before you even get to the doctor's office in some cases. And as with Mount Sinai and all of the tentacles, or whatever they are, as Dr. Simpson mentioned, many medical systems now are very large and share one common computerized electronic medical record system. So if you are going to providers at different sites even, but within the same medical system, they may already each be sharing your information. And if you know that, it can also save you some time or legwork. You don't have to worry about bringing copies of things because you know that they already have them. So you can confirm that as well. All right, let's transition to the visit itself. Toward the beginning, one thing that I want to mention, because I think we all know about, sometimes we think a lot about like the medical history and the diagnosis and so forth. But one thing that I would say is don't leave out, and I'm going to call it the personal. And what I mean by that are things that are happening to you in your life that may not be directly related to your diagnosis, to your treatments, but something that can have a dramatic impact on the way that you're able to carry out a treatment plan, or that may be impacting your health right now as well. This could potentially be some source of stress in your life right now. This could be a logistical hardship in getting to appointments. And so if something like physical therapy or was recommended, it might actually be very hard for you to get to those appointments if you have transportation problems. And this is really actually very important for your provider to know. So don't discount these things. There may be some financial issues that would make it harder for you to afford certain types of treatments if they weren't completely covered by insurance. This is very personal, but this is important, and it's very important in expressing this to your provider so you can work together as a team and find things that will be good for you in terms of treatments at this point in your life with everything else that you're going through, because you're not just your symptoms or your disease, but you're really a whole person with everything going on around you, and that's really what we need to address in order to optimize treatment. So taking notes during a visit can be very helpful. It can help you kind of in the moment register things a little bit better and also remember things better afterward. Bringing a family member can be extremely valuable, and I think even with patients who are or a friend for that matter, can be very valuable. I think there's so many patients who are clearly highly intelligent, sophisticated individuals, and there's so many times where then their friend kind of elbows them a little bit and says, but you haven't told them about this one thing, or remember that one time, or remember you wanted to ask XYZ. And so I think this is really important to think about. Asking the questions, of course, that you wrote down in advance. If there's something that you're really afraid of, be honest. Say what it is. Sometimes I even get a sense patients are anxious, and I'll say, is there something that you're really worried about or you're really afraid of? And people will say, I'm afraid that I'm going to be in a wheelchair, or I'm afraid that I'm not going to be able to spend time with my grandchildren anymore, or it's really helpful to voice these concerns. It's important for your doctor to know that. And there are some cases where that might not even be something that's very likely to happen, and so that can really be helpful for you because you don't have to carry around that fear anymore. But I think that, we read stories and look up case examples, and oftentimes we see the worst examples, and I think expressing those fears is so helpful during your visit. If you don't understand something, stop and ask the physician to explain. Ask them to explain it to you using different language, or if they can draw it, or if they have some sort of pictures or visual aid to help you explain it, because understanding is really, really key. Working collaboratively as you're wrapping up. So when you're making decisions about what's the treatment plan, what are you going to do now, what are you going to do later, what are the testing options, are you going to do all of the tests now or do them step by step and see what the results are? Work collaboratively. So if there's a treatment plan that your doctor recommends, make sure that you feel you understand it and it sort of feels good to you, feels right to you, and you're able to do it and you're interested in doing it. Share your worries about possible side effects, or if you are concerned about a certain treatment they're recommending, ask about other options. And don't be afraid to ask them to help you understand what other options might be, even if it wasn't something that they recommended first. Let your doctor know if you need more time or education about something, because honestly, they can not only take that time during the visit, but there are often many other resources that they have available to help you. In some cases, there may be a nurse or some other form of assistant who can provide more education to you separately during that same day at that same visit. There may be websites or support groups or other information online that is excellent, that is great for them to recommend to you, because it can be very difficult to find on the internet what the best sources of information are. There may be other handouts that they can give you that you can take with you that day that may be valuable. And sometimes certain offices will automatically be giving these to you, but sometimes if you feel like you need them, if you speak up and mention them, you can make sure you're getting all of the materials that you feel like would be important for you. And transitioning at the end of the visit, so this may or may not apply in all situations, but talking about will you have another appointment and when will that appointment be can be helpful. Making sure that your appointment timeline is, if you feel like you've not been doing that well and they suggest 6 months, but you say, I really am not feeling well, I'd like to come back in 3 months, I would make sure you speak up about that, because it is a two-way street in making the plan for your care. Again, talking about other resources, and in between visits, this is actually something that's very interesting, and there's a lot of new technology that's available for this. So historically, I think, people would maybe call their doctor if they needed to ask a question in between visits, and then sometimes the physician is busy, and then you have this kind of phone tag situation. But increasingly, or maybe you get somebody else who's covering. But increasingly, there's opportunities, especially for people who are comfortable using kind of the internet or email or typing, where many times there's options where you can actually write to your doctor back and forth. I know that our system has a patient portal where patients log in securely. It's completely protected, and we can write back and forth about patients' questions or concerns or test results at any time. It functions very much like a confidential email, and it's something where all the messages are automatically part of your chart. So this is actually really very useful, and you can send messages around the clock anytime, and anytime the doctor has time to look at it, they can reply, send you other web links or other things, you can see all your results. So asking about this, if your doctor has something like this, can be very useful. Also finding out, is there somebody else, like a nurse or somebody else who they work with who might be a good resource for you to contact between visits, who might be more available to speak on the phone? And if so, can you meet that person in person when you're there for your visit? They might not be a part of your visit, but I think it can be really nice to have that face-to-face connection with somebody who you might be talking to a lot in between your visits as well. If tests are ordered, asking about what are all the most convenient ways for you to get the results and discuss the results, whether again it's another visit or using their electronic medical record system and accessing your records online, or if you need to request copies in other ways. Next, what I'd like to do is transition to the second part of this topic, which is looking at non-pharmacologic management of pain. And I just want to preface this by saying I'm talking about, it was really interesting for me to go through and put together this part of the talk because there's so many different things out there. Oftentimes, some of these things I was reading about in depth with patients, often ask me about, and it was interesting getting a lot more information because as neurologists, when we go through our training, we learn a lot about certain things, like the medications that we spoke about earlier this morning. We don't learn a lot about all of these different modalities, in part, I think, because some of them are more or less proven to be reliable. But it is interesting because patients find a lot of this, they hear about it, they read about it online, and so I hope that I can provide you with some useful information so you can be kind of a savvy consumer and maybe learn a little bit about questions to ask when you're hearing about some possible new treatment. So one of the first, when people talk about integrative therapy and what does that mean, and in essence that's, some other names might be like complementary medicine or alternative medicine, but actually the term integrative therapy, which is where a lot of these fall under therapies that try to look at the patient as a whole person, and sort of look at lifestyle options for treatment and all these different broad capacities for intervening upon pain or neuropathy. So a survey of 180 outpatients with peripheral neuropathy in 2004 found that almost half of them were using complementary or alternative medicine, most usually for pain control. And this is kind of a list of a number of the different things they were using. And of those patients, about a third of them thought that their neuropathy symptoms improved as a result. So this is interesting because we can see right off the bat that using these things and trying them is very common, and that the benefits may or may not be there, even just serving people across the board. So one thing I want to talk about is nutrition and exercise, and a lot of the studies that we're talking about here really relate specifically to diabetic neuropathy, because I think we have a lot of very good evidence that controlling diabetes or preventing diabetes is very effective in treating or preventing diabetic neuropathy. So looking at maintaining a normal glucose, according to some studies, may reduce the incidence. So preventing diabetic neuropathy can be useful. And eating well and exercising, there were some studies where they looked at even just the benefits of walking. So I think that, sometimes people associate exercise with having to kind of join a gym or something else, but the idea that this can be something simple is going for kind of a good walk several times a week. So in patients with diabetic neuropathy, there was also a number of studies about yoga where they showed benefits, including improvements in diabetes, improvements in BMI or body mass index, which essentially alludes to kind of losing fat, improved cholesterol levels, blood pressure, better energy, and a sense of well-being. And actually, there was one study where they looked at the nerve conduction study velocity, so the testing piece for neuropathy in patients who'd done yoga regularly, and they found there were some improvements there. But one thing I want to start to highlight here, because I want to try to help you read these things carefully. So one might say, aha, I'm going to run out and now start doing yoga all the time. But no, wait, maybe you could do yoga and that might help. Number one, the particular caveat about yoga, there are some types of yoga which are really not good for patients who have balance problems, or some of them are way too vigorous, some of them are bad for your spine. So first of all, knowing what kind of yoga are you thinking about to begin with. But even if you found a type that was really good for you, take a look at this. This study, people did 30 to 40 minutes of yoga every single day for 40 days in a row. Like, that's a lot. I like yoga. I've never done that much yoga. So I think thinking about these studies, like, what does that mean? And even if you had this 1 meter per second, like, does that even, what does that mean? And does that even translate to an improvement experience? Looking back a few slides earlier, we saw all of these patients who tried all of these different modalities of these alternative treatments. Only a third of them even noticed improvement. So a lot of times when people publish papers in science, there's a threshold in statistics, in math, where they have to come up with a certain percentage of improvement, and that's called statistically significant. And when you get to that threshold, which can be very tiny, then it meets the criteria for a good result where they can publish it, and then it becomes filtered through into the New York Times or what have you as saying, yoga cures neuropathy or something like this. But when you say, wait, hold on a second, and then you'll see the first paragraph will say, research study shows that yoga cures, improves nerve function, and neuropathy patients should do this. If you back up and you say, what does this really mean? I think what we're going to talk about with these different things is reading the fine print. What was the design of the study? And this can be hard for patients to do on their own, so this is where engaging with your doctor or another organization, I'm actually going to be trying to help provide some of these resources with interpreting articles as well. I think really trying to see how can we help to better educate people so really you're savvy when you're looking at these different options. So moving on to Tai Chi. So there are some studies that show that regular exercise, again, we're still talking about diabetic neuropathy, regular practice of Tai Chi for months. So again, not just kind of I'm trying out Tai Chi, but you really get into a very regular schedule, can improve walking, balance, strength, foot sensation, diabetic control, and nerve conduction velocities. So again, when you dial down into these studies, it's a it's a relatively modest effect. This isn't a cure. It is a benefit. One thing that I would say is an advantage of Tai Chi over yoga, if unless you have a very specific type of yoga, is that Tai Chi is very gentle and safe and can be appropriate for patients with neuropathy. Mind-body therapy has also been studied. Another term for this that we're using here, there's different things like meditation and so forth. This particular study I'm talking about was biofeedback. Biofeedback is essentially a way that to increase your awareness. I think we all know, we've heard terms like, oh, I'm so angry, my blood is boiling, or the white coat syndrome where you're anxious and nervous and your blood pressure is higher than it normally is when you get to the doctor's office. So there are really true examples of how our physiology or our body reacts to our emotional state. So biofeedback is kind of using that, but in the opposite direction. So can you kind of calm yourself down, slow your breathing, do these things and actually help lower your blood pressure, and in some ways alleviate stress, and in some ways alleviate pain. Even though you may not be making the neuropathy better, your experience can improve. So biofeedback has been shown to alleviate muscle tension and anxiety and perhaps improve diabetes control, which could benefit neuropathy. So again, this is tangential, we can see already. But on top of that, there's a lot of variables here. You have to work with somebody who can teach you how to do this and know that it's a good kind of matchup with somebody who has the right credentials. And then you have to have this equipment that kind of shows you your blood pressure and so forth, and then continue on with the work at home. So again, I think there may be some benefit in terms of, in particular, reduction of anxiety and reduced kind of stress levels for biofeedback or other forms of mind-body therapy like meditation. Will it really change things in terms of the essence of what's happening with the neuropathy itself? Probably no. So this is, again, kind of something that you might see kind of advertised as a treatment for neuropathy, but it's more that it can help maybe make your life better given that you're living with neuropathy, but not treat or cure the neuropathy. Transitioning into a field called bioenergetics or infrared therapy. So there's a use of these different, essentially like phototherapies that sometimes are in like these pads that are delivered and you put them over different parts of the body. I think that this is most commonly published in the podiatry realm in terms of foot symptoms, but I've definitely had patients ask me about this. And when you look at sort of the research that's questioning why does this work, there's somebody did some research where they found that using a certain type of light helps red blood cells release nitrous oxide in the blood and help improve circulation and so forth. And they thought that better circulation then would help the nerves. So again, we're a few steps, and it's kind of a hypothesis. And in practice, it may not be that robust at all, to be honest with you. So, but you will definitely see it there, and I've definitely had patients come and ask me about it. Anodyne therapy is one of the more common commercially available systems. Again, I think people often have this at like a podiatry office. And there was some studies that said that there was some reduction in pain and improvement in sensation and balance in diabetic neuropathy patients, but only when they had very mild neuropathy. So again, really diving down and seeing, even in studies where they thought that this was somewhat useful, would it apply to me, even in the research study? And in some cases, here they found in some of the patients there was a slight benefit, but in a lot of the patients there wasn't a benefit. And then one thing we don't know for a lot of these techniques is something we call follow-up. So what if the patients felt better for a few weeks or a month? And how do we not know that that was placebo? And what happens after that? Did they feel then back to themselves, with no benefit after a couple weeks? So these are all really important questions to think about, because sometimes these interventions are not covered by insurance, and that can be a very costly endeavor. According to another study, there was another form of light therapy where they found that there was some benefit maybe in patients with more advanced diabetic neuropathy, but again, it's really important to look at things on an individualized basis and be cautious before embarking upon these things and having good communication with your neurologist. Actually, there's also people who use magnets and magnetic insoles to try to help pain associated with neuropathy. So there's some research, they thought that the magnetic fields actually penetrate the skin and somehow target pain receptors in the skin. So they did a randomized trial. So they had some people who had neuropathy who wore the magnet insoles and some people who wore other insoles but that had no magnets. And they found that people who wore the magnetic shoes for 4 months had some, again, significant, this is the research term, so it could be the tiniest amount of improvement, but if it meets this mathematical threshold, they call it a win. Reduction in burning, numbness, tingling, and pain. And this is one of the brands, is these mag steps, which we have a picture of there. And there's other types of magnetic nerve stimulation showing that some of these treatments are effective and safe for reducing pain. However, this other study showed that there was no benefit after 3 months. So they actually did do a little bit of a follow-up, and I didn't put the rest of the information there because it only got worse from there. But I think the idea being that looking at these things, and you can easily, you can actually just look on Amazon and buy some of these insoles. They're everywhere, and they'll say treats nerve pain, treats neuropathy. So I think, it's worth knowing about this. Maybe this certainly wouldn't be harmful, wearing a certain type of insoles. Maybe it wouldn't be that expensive. So if the patient were to ask me, could I try this? I would say, well, if it's not going to be, a financial burden and it's not going to interfere with your life, the risks are low. We don't have a lot of great evidence that it will really make a difference. I think we should look at other options too, but if you want to try it, I won't object to it. So I think weighing again the risks and the benefits, but really knowing what you're getting into in terms of what type of science do we have to show, is there a benefit or not? So acupuncture is one of the fields where we do have, across a lot of different areas in medicine, evidence that it can be beneficial for various types of pain. Usually these benefits are, especially for chronic painful conditions, these are more transient benefits, so it's not something that's likely to kind of be a cure, if you will, for chronic pain. But there is evidence that shows that acupuncture and electroacupuncture, where they put little electrical stimulation on the needles, also helps raise your body's endorphin levels, and then again helps alleviate pain, but on a not on a permanent basis. You'd have to have, again, regular treatment sessions. The full physiology is not entirely known, but there are a number of studies which have shown improved pain and improved nerve conduction velocities, which we don't understand the physiology of why that would be the case. But some patients were able to reduce or stop their pain medication using acupuncture. One of the big caveats I would say about acupuncture is that it is highly operator dependent. This is not something that's automated. This is not like the magnetic insoles where you put them in your shoes and you walk with them and you know that you're getting whatever it is you're supposed to be getting out of it. You have to know that the person has a proper training, that they're licensed, that they're experienced. So vetting who your acupuncturist is very important. Sometimes people, when you look at the breakdown of how often are people going, sometimes they're going for treatments every week. And some insurances are covering acupuncture now, but not all of them. And if they don't, then it can be $100 a session, or more or less, depending on where you go and so forth. But it's not inexpensive. And so it's important to really understand that sometimes there may be obstacles, but this could be potentially good option, I think. And it's important, though, to realize what the training is and that the facility is clean and reliable and so forth. There is actually in New York City and in other cities, there's a school called the Pacific College of Oriental Medicine, which is a large institution, which I think is very reliable. And actually, my medical school, we actually went and visited and kind of did an exchange program, where as medical students, we had acupuncture and experienced that. And I thought that was kind of an interesting foray into this field. But the idea being that it's important to know, is this something you can afford, and are you going to a provider for this who is really going to be able to work with you and be very qualified. I'm not going to get into all of these different botanics, but I have one slide just showing you a list of, these are a number of different botanical medicine, not, some of them are vitamins, but some of them are not vitamins, but all of these have been described in various ways as benefiting neuropathy or neuropathy pain. Now this is, I would say, distinctive. As we mentioned during the question and answer session, we definitely know that deficiencies in certain vitamins can actually cause neuropathy. And if you are deficient in vitamin B12 or deficient in vitamin B1, then that could be the cause of your neuropathy. And I wouldn't be thinking of this as an alternative treatment. I would be thinking of this as an absolute indicated medical treatment and possibly cure for your neuropathy. End of story. But here what I'm talking about is that some individuals endorse taking high doses of these megavitamins, even if your vitamin levels are normal, because they think maybe that will help neuropathy too. And the idea is that we really don't have strong medical evidence for that. The other thing to bear in mind is that, again, I think as Dr. Robinson-Papp mentioned, some of the B vitamins and other things, if taken in excess, can have toxic effects. Some of these other herbal preparations can potentially have interactions with other medications even. So, and sometimes if you buy something that's billed as a supplement, it contains a lot of other ingredients. And so it's important to be able to have your doctor work with you and read labels and see like what is really in there. Is there something else in there that could actually be causing harm? And some of these can be very expensive, and we just don't know if they work. So I think it's important to talk to your doctor and again, weigh the benefits and the risks very carefully. I think we've really talked about a lot of these caveats, but I just wanted to kind of summarize them conceptually here. So there may be some small benefits, sometimes transient benefits for some people. And so I definitely weigh the risks and benefits with each patient who's interested in some of these modalities. We talk through, what are the expectations in terms of might it work, might it not work. I never want somebody, if they don't have a lot of financial resources, to be spending money on these things. We look and try to vet an acupuncturist if they're interested in acupuncture, all these sort of things. So it's important to realize that there is lack of standardization in these modalities. A lot of these studies are small, or there was like one study that was small that showed maybe a very brief benefit, and we don't know what happened after that. Potential toxicity is important to be aware of. Vetting, if it's something where you're going for treatments or procedures, so forth, is very important to look into the qualifications and then the expense, of course, as well. So a lot of references here, a lot of information online and elsewhere. So I think it's very interesting and important to partner with your doctor to have conversations when you're interested in these things. Thank you very much.
Well, thanks very much, Shanna. So we're coming up to our final speaker, and after Mary Catherine's talk, we'll have another question and answer period for the two speakers now and for Jessica and myself as well. And so let me now move on and introduce Dr. Mary Catherine George. Mary Catherine is another cherished colleague of ours in our Department of Neurology, and personally has been a tremendous asset for me personally, and that Mary Catherine has worn the hat of being the Senior Research Program Coordinator. And basically, with that hat, Mary Catherine has coordinated many of our research studies, including those in peripheral neuropathy, our educational programs, in which we outreach to physicians, medical students, the lay population. And after all that, Mary Catherine has also pursued a PhD, and in particular focusing on health psychology and pain. And she and colleagues are working with some very innovative new technologies, including computer-based apps and iPhone-based apps, partly to improve communication between patients and their providers, as well as to advance some of the research in these areas as well. And so, Mary Catherine, let me get your slides up as you come up to us.
So, I got the research bug back in 1990 when I was working in HIV disease, and I haven't been able to let go of it since. So I really have to say something about the Peripheral Neuropathy Foundation, just briefly. Because of the Peripheral Neuropathy Foundation's willingness to put together this wonderful registry, I loved what Lindsay said about we don't know who has peripheral neuropathy unless you tell us. So coming to see the doctor and coming to tell us about your pain symptoms and potentially thinking of becoming a member of the registry, this research, certainly gives us an opportunity to reach out to you in the future for us as researchers so that we can offer you some of the most cutting-edge research that's available, whether it's a medication or a technological device. So I have to commend them that some of the reasons that we do a faster process of reaching out to patients is because we have this access to a registry of people who have diabetic neuropathy, who have small fiber neuropathy, who have HIV neuropathy, who have idiopathic neuropathy, that we can potentially put together small studies so that we can begin to understand some of the other types of treatments that might be potentially available. So if you're thinking about becoming part of the registry, come see us. We would certainly welcome it. So my talk is about research and technology, because I think since the beginning of the technological advances that started to show up, I became fascinated in them and how they can potentially help us by measuring our heart rate, our walking, our ways of interacting with ourselves, increasing our awareness. So how can that potentially help us in reducing pain? Because I think at the end of the day, when you have neuropathy, that's what you want. You want to reduce pain. So the things I'm going to talk about today are virtual technology, devices, apps, some of our behavioral research, and then what could be next. So I just want to see a show of hands. How many people have more than one device? More than a smartphone, they have a tablet, they maybe have a computer at home. How many people have more than one device? Oh, okay. So we have a lot of people who are already engaging in the technological dynamic. So I wonder if you feel any of this. Does any of this stuff work? Does it take all this time to learn it? How much money or attention do I have? And I think that that is what we feel in the medical field as well, because innovation is happening at a speed that is almost hard to comprehend. In fact, when they look at what kind of medical innovation is going to happen, we're talking about 10 to 50 billion medical devices that will come into the mainstream over the next decade. And how in the world are we going to understand what works, what doesn't work, what's going to help, what's not going to help? I think what I love about this picture is that we have people in a beautiful museum, and what are they doing? They're engrossed in their tablet. Or I think of the FDA, when we send off the devices and technological advances to the FDA, and they're looking at, like, how do we measure and understand what works? And so the key is to do the research, to ask the questions, to systematically work with patients who have the problem of peripheral neuropathy and listen to what works for you collectively and see how we can advance using technological advances and medications so that we can give people functional lives and lives that they enjoy and that they find that they have tools that they can begin to reduce the pain and increase their enjoyment of their life. So one of the things that we are looking at very soon is something called virtual reality. So I think when we all think about virtual reality, we think of entertainment. We think of the gaming industry. We think of, of some kind of fantasy world. But how does that have any kind of benefit in the medical domain? Well, we're looking at how can we create a virtual experience for people who have neuropathic pain and see if this type of immersion into another experience potentially can reduce your pain. For example, when's the last time you had a book or a movie or some type of a hobby that you participated in that you lost all sense of time and awareness? That is the concept behind virtual reality, is where you are taking a computer system of goggles and earphones and offer yourselves an environment that potentially would give you a sense of no pain. Now, is that possible? I'm not sure. I can't get over how wearing the headgear would feel, or in some cases, if there's a very developed type of sensitivity that you can have with some systems, they actually give you the ability to feel a sensation as if you're grabbing something. But that is still probably in the works. But this is such a huge field. There are like 230 companies who are all working to improve the virtual reality. So we've collaborated with what's called the Activities Lab. There's a rehab doctor, his name is Dr. David Petrino, who's been doing virtual reality studies in patients who have spinal cord injury and neuropathic pain. And we were talking to him about the improvements that were seen in his patient population. And so we said, well, why can't we offer this to our neuropathic pain patients who have HIV or diabetes? So we currently have a study that we're hoping to begin enrollment, where we're going to look at a chronic neuropathic pain feasibility study using this technology. And the goal would be to have the opportunity to let people be randomized to either a type of immersive experience that's playful and fun, maybe using your feet and your hands in ways that you haven't used them in a long time, versus an experience that's more reflective or passive, where you're just wandering through some beautiful fountain or a beautiful meadow, or if there's beautiful sounds of running water or the wind and you're seeing the leaves blow. And I have to say, when I've tried it myself, it's really quite amazing that you do get engrossed, but I don't have chronic pain, so I'm just having a fun time. So we're wondering can we answer this question about virtual reality and pain reduction by enrolling about 30 HIV patients with neuropathic pain and 30 diabetic patients with neuropathic pain. What's terribly difficult, though, is that we need people who can come in like every other day. They need to come in and do a 20-minute session like Mondays, Wednesdays, Fridays for 4 weeks in a row. So it is very time-intensive, but we believe that at least this will begin to give us some initial data around what is meaningful when it comes to a virtual reality for people who have chronic pain. I think right now the virtual content is, I think they have someone playing with paint and using their feet and some other types of playful things. But I don't know if that's going to be meaningful for people who have neuropathic pain. And in the virtual realm, it's the content that is the key. And the long-term goal would be to be able to give people goggles that they could use at home and go into a YouTube channel and use the pain relief whenever they felt like they needed it. So we're looking for that in the next, I think we're going to start enrolling this study in the next month. I think the only thing that's a problem with our exclusion criteria is that if you do have a history of dizziness or motion sickness, because of the way the virtual reality realm works, it's like it tracks your eyes. And so wherever your eyes or your head move, you can get a sense of dizziness or motion sickness. And so that's the trouble with the virtual realm, is that it's not quite without its drawbacks. So the next thing that we are also contemplating is a very interesting device that was developed by an individual who suffered with severe chronic pain. There was a young man who was in a car accident, a very bad car accident, and he was very badly injured. He was in a coma, I think, for about 6 months. He came out of it with a lot of very severe neuropathic pain. And he was very frustrated. He was like, why can't I find something that helps me with my pain relief? But he recognized that when he watched a good movie that he really was immersed in, that he forgot about his pain. So he pulled together a group of engineers and some developers, and he put together something that's called the Sana neuromodulation for sleep and pain. And this device is a mask with some earplugs that basically has tones and lights and sensations, basically vibration that's supposed to be a closed biofeedback loop, where it reduces the, I guess, like the theta waves or the types of waves in your brain and brings you into a relaxed state. This device has won several hackathons. It recently won at MIT for its presentation, and we're very excited that we're going to be collaborating with the Activities Lab to see how we can bring this device to some of our patients with neuropathic pain. The studies that they did with this, though, I think are somewhat flawed. The 75 people that they randomized to these 12-minute placebo or 12-minute using the mask, they were all kinds of pain. They weren't just neuropathic pain. They were fibromyalgia, they were back pain, there were some healthy controls, but they did have some very good results because most people, when they wore the mask, they fell asleep in 10 minutes. So in some ways, it's a very interesting device that we think has some usability. The goal of the study that we're looking to launch would be, again, sending people home with the mask, having them use it as they needed to for pain, but at least once a day. I think it's going to be, again, like over a 12-week period. And basically, putting inside a tablet that's paired with the mask how you're experiencing the mask and how you're experiencing pain. And we're hoping to launch this in probably early 2019, but that's going to be dependent on the FDA. Right now, the device is being reviewed by the FDA as far as its usability and meeting some of the standard regulations of what's necessary for a device. And I think they're also still looking for, I think, $1.3 million to get the development off the ground. So that's also one of the drawbacks with technology, is not cheap. The next device that I'd like to talk to you about is called a micro-impact resonant frequency technology. And this is something that's made by a company called Juvent. It's the Juvent platform. And what's very interesting about this device is that it really is a fitness device. It's something where you have a low magnitude of a mechanical stimuli, which is primarily these, again, slow level of waves that are pulsing at very resonating frequencies. It's super safe, it's very small sensations, and the goal would be to help people increase the blood flow in their feet, increase the ability to stand for a period of time. I think they have to stand on it for 10 minutes. And then to eventually get where they can see if this would reduce their pain. Now, it's unclear about whether this has real pain reducing abilities, and that's why we have to do the study. So it has shown in children and in some animal models to have some good results. But we need to do something with our pain population, and that's the goal, is that we would launch a pilot in early 2019 looking at how we can reduce pain in diabetic peripheral neuropathy in potentially about 20 patients. I think the challenge here is, again, coming to the lab, standing for 3 to 5 days a week, because that's the goal, is to use this to show real improvement. We're going to have people coming repeatedly, and that's a little bit of a challenge for patients to come so frequently. But we are excited to look at this because I think exercise in diabetes, or exercise when you have pain just in general, is a difficult thing. And if you knew that you could do something very small, like stand on this platform for 10 minutes, and that would be some kind of intermediary between walking and sitting, and if you stood, then that might be something that gets you eventually to where you are walking a little further, and you are participating in more functional activities with less pain. So now apps. So for about 2 years, I've been working with apps to try and figure out how can we look at apps and see what they can do to help us understand more about our human experience. And I think one of the ones that I've kind of chosen to highlight here, Ouchie, is because Ouchie was a very socially driven pain community. It was very social interaction, and it rose to the level where 4 medical facilities have now partnered with Ouchie so that they can provide it to their patients. It's nothing really different. It just basically has this wonderful social interaction. It almost feels like the Facebook for pain, where you're talking to each other, you're sharing, you're talking about how your day went, but you're also tracking information as well. The other app that I think we're very interested in is MyMe. And this is an app that was developed by a woman who was very frustrated because she too felt like she wanted to have something concrete that would allow her to tell her doctor, this is what's going on with me. So she put together this app called MyMe, and what's really unique about this app, which I think is fascinating, is she has health coaches that are part of the support system. So if people are frustrated about whatever's going on, they can reach out and get a response from a health coach. And that, as Shanna had said, something about when people are heard and they feel listened to, or that in communicating with people, that they feel that potentially their pain is less. So the MyMe app is one that we're thinking of somehow collaborating with on several of our studies. Now, within our institution, we have something that's called the Sinai App Lab. And we've been working with them intentionally, with Dr. Robinson Papp, because they've developed another system which is fascinating, where it's not so much an app, but you're actually prescribed a way of tracking what you're feeling or sensing. And so a link is sent to your smartphone, which you open, and you complete the information. So to me, that seems to be a much easier approach, and we're still kind of trying to understand how that can be something that patients will use and find friendly, but it's still to be seen. But that, I think, is a much easier approach, and plus the prescription process of it gives you a sense of this is something my doctor understands and supports me using, and I can also see that they see the cumulative information that I'm providing. Now, behavioral interventions and technology. So one of the things that Shanna had mentioned is meditation. But I think everyone finds meditation can be quite challenging because when we sit down, we feel like flies are going to get us, or our mind won't shut down. Nothing will be quiet, and that I'm just basically chattering away. And it's very difficult for me to meditate. But the truth is, meditation does change our physiology. There are some good studies that have shown that meditating consistently can be a very helpful improvement for people who have pain. It can help you calm down and recognize the parts of your body that don't hurt. And that can be very key when it comes to our attention and our awareness. So one of the concepts that we're considering of doing is to develop a phrase that people believe in, that in sometimes transcendental meditation, they give you a statement or they give you a word that you can repeat. And so this would be the same thing, is coming up with a phrase that you would repeat while you're meditating, so it gave you some kind of an action to do. And then you would be randomized to either do the mantra or the meditative phrase alone, or you would do it in combination with a simple physiological stretch, like your ankles. You know, we are really grounded from the foot up. And so if we can all become better at stretching our ankles, strengthening our ankles, making them to be the best they can be, that's going to be, in the long run, a healthy approach for walking, standing, and potentially just increasing the blood flow around your ankles and feet. So the concept here is to combine this with the support of an app, so that patients would be sent out with one or both of these methodologies, either the mantra meditation or the mantra meditation plus the rehab strengthening of the ankle, and then they would be engaging in the app throughout the 8-week period to get the support, to get the reinforcement of the two practices over that 8 weeks, and then have them come back to see if this is something that helped them have pain improvement. Now, this is a pilot that we've sent out for potential funding. Of course, that's always the case. When can we get the funding is ultimately what depends on whether we launch something or not. But this is something that we think, by combining behavioral methodologies with a technological support system, that we can get people to have better pain relief and better engagement in their life. Now, finally, an area that is one that's dear to my heart is language. So right now, when we think of pain, we think of the number you tell your doctor or some kind of a measurement on a scale. But the truth is when you're talking about your pain, you're using your words, your adjectives, the expression in your language. You might laugh, you may pause, you might have some word searching because you can't find that word that really tells the doctor or whomever you're trying to communicate to, what is this pain like? In a study that I did for my dissertation, we looked at two groups, HIV and diabetics. And what was very compelling is nearly 40 adjectives were used by these two groups that went beyond the standard of what we normally think of, like stabbing, shooting, hot. There were many more adjectives that people used. And they were also laughing, and they were also sighing, and they were also pausing. And so in my thoughts, I think this is potentially a place, a resource for us to measure pain. So we've been in some discussions with a very well-known software company, because there is the software now that can take language, it can record what you're saying, it can calculate the types of words you're saying, it can tell you the inflections, it can tell you the pauses, and it can tell you these nonverbal expressions as well. And potentially see if that, measuring what you say about your pain, is potentially something that could give us a clearer understanding of what your pain experience is. So we're very hopeful that by looking at pain and the ways that you describe pain could potentially be a way we measure pain, because that's what technology really is offering us now. Now, it may be a bit intrusive, or it feels maybe a little bit intrusive. You know, you're going to measure my language, you're going to take what I say and make a copy of it. But the truth is that we don't understand pain. We don't understand your individual, singular experience of pain. And so how best to try and understand that, except to look at how you talk about pain, both in the words that you choose and how you choose to say them. Because there has been some good studies in some other psychological problems where there is an indication about how people talk, that it does somehow give us a window into what the experience is that a person is having. So we're very hopeful. We've submitted a small pilot grant to see if there's some way that we can begin recording about 100 to 200 patients, and taking that language compared to just a plain piece of script that they read, and see what's different about when you talk about pain. We might even add a component where you talk about what if you had no pain, and see what happens to your voice and your word choices then. And again, that might give us bigger insight into your experience, both with and without pain, and how we can be better at understanding what your experience is and your struggle when dealing with treating your pain. So, in summary, our technological advances, they can potentially offer us pain relief in conjunction with our treatments. They can help us track our health experience so that we can see how we can have better treatments, that we can have access to resources for patients and providers that aren't normally available through an app, or we could potentially, through language, develop a new measurement for pain. So I want to leave you with this final thought, that technology ultimately is only good as how we can interact with it. I love this because it's saying, you know, I miss only having to remember the combination to my locker. And the truth is, that's always the problem, is that if we don't use technology and understand it, and we don't make technology easy and usable, then it's no good for anyone. Thank you.
Thank you. At this time, I'd like to open it up for questions and invite the four speakers to come up just in case any questions pertain specifically to their presentations. Before I turn it over to those in here, there was one question that came through online that I wanted to ask on their behalf. The question is as follows. Is there evidence at present that stem cell treatments are effective in either reducing neuropathic pain or repairing nerve damage? Positive claims are being made in the local and national media, and I'm skeptical myself.
Well, I'll take a stab at that, and then perhaps any of the other speakers might want to comment. I think the final point in that question is the most important one, and that's skepticism. And by that I mean whereas stem cell research is extremely exciting and holds some great promise for the future, and there are diseases that are being pursued very rigorously, one, for example, being ALS, in which stem cells are being implanted into the spinal cord in a very rigorous, very carefully controlled environment under the auspices of research studies sponsored by NIH. Those types of studies are critically important to advance the field. However, the skepticism part probably needs to be emphasized even more. And that is, there are clinics that are opening around the country and around the world that are uncontrolled, that are run by individuals without the proper scientific credentials, in which a lot of very strange things are happening. And there was an example last year where stem cells were implanted into the eye of a patient in one of these uncontrolled environments and caused blindness. And so I would approach this with a tremendous amount of caution, and not to say that the research doesn't need to go on, but I would be very concerned about going into one of these self-proclaimed experts in an uncontrolled clinic situation. I don't know if anybody else wants to comment or if we'll move on to other questions. Okay, with that then, let's open it up to the audience, and you can direct your question either to all of us or to one of the speakers specifically.
I think this is to all of you, just a comment about medication can only go so far. You're never going to get 100%, but I think these other mechanical devices can provide that diversion. Virtual reality, I've tried it. It's for those 10 or 15 or 30 minutes, the pleasure is greater than the pain. It works. No different than a orgasm or something. You don't have feet pain at that moment.
That's your next site of research.
Okay.
But I'd like to also comment on or ask about, you didn't mention massage slippers, which do the same thing, and especially reflexology. Can you comment on that, where the pleasure balances out the pain for that time of reflexology?
Well, I think anytime we're engaging the dopamine, release in our bodies, that's going to be a good thing, because that's going to lead you to feel less pain and more pleasure. And I'm not sure what kind of immersive virtual reality experience you had when you tried it. And I think that's the key. If we are having you do a virtual reality experience where we're really showing you another experience with your feet and hands that you haven't had in a long time, having them feel normal in your mind's eye, or having you play with things with your hands and feet in a way that you haven't done. I wonder if that might offer you a new perspective. We're thinking that this may have, hypnosis types of impact, where even though you're just doing it for a very short time, that you might have something where you can reflect back or think back and put yourself into somewhat of that same state.
I was in space avoiding
So I would just like to add something about that as well. One of the things that the CDC recommends for chronic pain treatment is this bucket of non-pharmacologic therapies. And that's up there. That's the first thing that they say. And each individual one may not have a lot of evidence for it, with the exception of acupuncture, which is probably the best proven one. But what we do know is that it's very important for people with any kind of illness to take a positive role in self-managing that illness. So if that illness is pain or neuropathy pain, what can you do as that person when you're experiencing an exacerbation of your symptoms to have a positive coping mechanism, to not get catastrophic about that symptom, but to say, I've got this, I can handle this. And everybody does that in their own way, which is why probably each individual therapy is not going to show a lot of benefit over a population, but it is critically important that we all know what we have in our toolbox to deal with our symptoms when we have them. And that's true for pain, anxiety, depression, any kind of symptom that we experience. And it has to be something that's not popping a pill, because that in the long run is very passive and will make symptoms worse. I mean, we do need our pills, of course, also, but there has to be something more proactive.
I'll just add one more comment, and it comes back to some of the comments we made earlier today about placebo. And let me see if I can frame this properly. When I mentioned bridging the chasm between being a research scientist and being a clinician, we wear two hats. As researchers, we use evidence-based medicine to prove things work in a very rigorous, careful fashion. I believe Shanna mentioned earlier the so-called statistically significant result, which is our gold standard, and in fact the FDA's gold standard for approving drugs. The problem is these studies are hard to do, the methodologies are often flawed, and the placebo effect, particularly in pain, can be huge. And so when we say a study was negative, that doesn't mean the drug doesn't work. It just means that the study didn't show it worked with this scientific fashion. At the end of the day, as clinicians, what we care about and what our patients care about is they feel better. And whether it's a placebo effect, whether it's one of these approaches that we don't necessarily have great scientific evidence for, if the patient feels better, and if the approach is not harmful or risky or overly expensive, I'm delighted, the patient's delighted, and I'm not necessarily looking to prove to the scientific community that this is evidence-based. It's just good clinical medicine. Other questions?
Yes, I was interested in your comments about non-pharmacological treatments for neuropathy. Clearly, there are all sorts of stages of neuropathy, from mild neuropathy to debilitating neuropathy. If you watch television, you'd think Lyrica is the right one for all of them. And I didn't rush out and buy any, by the way, or ask my doctor to prescribe it. But I did notice that you had a number of different non-pharmacological opportunities up there to work with neuropathy. But you didn't mention magnesium, magnesium sulfate, better known as Epsom salt, and there's other magnesium formulations that it seems to have proved to be of some benefit, especially to people that have early stage neuropathy, if you will, and reasonably inexpensive, from what I can understand, incredibly safe. And wondered if you had any thoughts about magnesium as a topical treatment, and if not, why not? So thank you.
Sure, no, absolutely. So first of all, I would have to say that, you know, it was hard to choose a subset of things to talk about. And I think, you know, this was kind of like a sampling that I felt like was fairly representative, but there's so many more things. And even a lot of the research in the virtual reality and meditation and a lot of the mind-based therapeutics, I kind of only scratched the surface, and reflexology someone's mentioned, and massage, and these things that increase our endorphins and dopamine and in some ways mimic the chemicals that are modulated by some of these drugs, and magnesium. So there's so many things out there, and certainly this was not meant to be completely comprehensive. And I have heard of topical magnesium being beneficial. I'm not exactly sure of what, and it definitely, to your point, is safe, and I'm not specifically certain about what the mechanism is. And I think that, you know, it's one of those things where, you know, I could actually do some reading and see if I could find, you know, figure it out and get back to you. But I think off the top of my head, I'm not familiar with what the components of the research are, but I've definitely seen it, and there's sprays and lotions and all kinds of things. I'm not sure exactly why magnesium topically has that potential benefit, and I'm not sure what the science is. But I would agree with you that it is safe and it can be relatively inexpensive. So I think that for somebody who may be interested in trying it, that I wouldn't argue against it. I just don't know. I don't know if you know the science behind it, but
for topical, that's I don't think there's a lot of proof of that. But I would add that we do use magnesium medically for other neurologic conditions quite routinely. And the ones that are most common really is seizures in the setting of pregnancy. So in preeclampsia, if women get very sick right before delivering, there's very strong evidence for intravenous magnesium as an anti-epileptic in that setting. And then there's also decent literature about magnesium as a natural supplement for migraine. And so there certainly is a lot of overlap between other anti-epileptics and neuropathic pain medications, Lyrica being one of them, right? And so it may stand to reason that some of those same mechanisms that make magnesium anti-epileptic might make it good for neuropathy. I'm not aware of there being good studies that show that, but certainly there's at least a mechanistic rationale why that might be the case.
I'll make just one comment about topicals. I said a little bit about therapies applied to the skin earlier today, lidocaine, capsaicin, but many patients avail themselves of various topical compounded therapies. You mentioned magnesium being one. I find patients coming in with this potpourri of mixed compounds, often mixed together by pharmacists or others, with things like topical gabapentin and amitriptyline and ketamine and God knows what else. And they're all mixed together in these formulas that are told to be put on the skin. Do they work? Who knows? Firstly, it's almost impossible to study these big combinations of things in any rigorous way because you don't know what's doing what. And there's not a lot of actual money behind this kind of research because many of these things are generic and pharmaceutical companies aren't interested. That being said, many patients feel they help. And it goes back to my comments of earlier today, is if something's not risky, and these aren't very much systemically absorbed, so there's probably pretty low risk, and if they're not overly expensive, then if they help, I am perfectly fine with that. But we can't say too much about it because we just don't have much information. Other questions? Yes. Microphones?
Just a question about remissions. I've had neuropathy for about 8 years, and in that period of time, I've had experiences where I've had periods of remission. I don't know why, it just goes away, and then maybe, in my particular case, 2 years later, it came back. I have no analysis of that. No one's ever explained it to me, but I'm just curious, what's your experience?
Shanna, you want to take a shot at that?
Sure. So I don't know what kind of neuropathy you have, but
Small fiber.
Okay.
Like classic portrait that was done.
Idiopathic? Idiopathic, our favorite, idiopathic small fiber neuropathy. So I think idiopathic small fiber neuropathy is so interesting. So interesting because I think there's so much about it we don't know. I mean that in an exciting way, although I can understand from a patient perspective it could be agonizing. But I think it's so interesting because there is a significant proportion of patients who have isolated small fiber neuropathy where they end up falling now into the idiopathic or we don't know bucket. And so I've had patients where they've had a whole host of different experiences where their pain, to your point, kind of seems to wax and wane and come and go, pops up in one part of the body, then pops up in another part of the body, then goes away for a while, or some patients where it's gone away altogether. And part of me, I feel like it's really fascinating. We know that in certain cases, I think there are some studies, not of idiopathic per se, but of patients who have small fiber neuropathy due to mild diabetes, where then they improved their blood sugar control and the nerve fiber densities actually improved with time. So we know that there can be some regeneration there, but of course, from a practical standpoint, we do not go around like re-biopsying people every time their symptoms change to see like what's happening, at the microscopic level. So I feel like, on one hand, could it be something about the neuropathy itself that's fluctuating? Could it be something about the symptoms that's fluctuating? Or could it be something about you and the rest of your body and what's happening that your experience of the symptoms is fluctuating? And I think that we don't know the answers to that. And I think especially in the case of idiopathic small fiber neuropathy, where some of these explanations, I'm really fascinated to think about what will it look like 50 years from now as that percentage, I would imagine, shrinks and we have more of a better understanding about what's going on. I think we may be able to explain that a little bit better. But I think those would be my comments on that. But I think it's very, very interesting, and I'm very happy when things feel better for patients for a period of time. It may be that we'll understand better what exactly is going on in the future.
I have a question. Are any of you familiar with the use of chemotherapy as a way of dealing with resetting the body's immune system if you suffer from an autoimmune form of small fiber neuropathy? There's Dr. Carlos Tornatore at Georgetown feels that that is a good alternative to the IVIG treatment, and I was just curious if any of you had heard anything or were aware of anything along those lines.
So that's a very interesting question, and I have definitely heard of patients and partnered with patients who were really interested and feel passionate about looking at the IVIG as a possible treatment. I hadn't heard of the chemotherapy. In principle, I'm not surprised because I think people are looking at, one of the things people are looking at in the we don't know yet realm for small fiber neuropathy in particular is, could this be some immune system mediated situation? And then the idea being, should we start to think about treating it like we treat other autoimmune conditions with things like chemotherapy drugs not used to treat cancer, but used to suppress the immune system in a way to kind of, like you might treat other autoimmune diseases. So I haven't heard of that research in particular. If a patient came to me personally and said, I'm interested in this, I would be extremely concerned because those medications can be very toxic and dangerous, and we don't have, and maybe this is a research field, but we don't have the actual scientific understanding that this is something that's definitely helpful for everyone, and it could potentially cause a lot of harm. You want to add to that?
Yeah. Well, it partly depends on how one defines chemotherapy, because that potentially covers a lot of territory. But what many people consider chemotherapy are the types of drugs one uses in cancer to treat cancer. And of course, we know that many of those chemotherapies are toxic and cause neuropathy. Vincristine and cisplatin and the Taxols and many others. However, there are other chemotherapies, maybe the kind you're alluding to, also used in cancer, that are now being used in neuropathy. One, for example, is rituximab or Rituxan. We heard Lou talk earlier today about his anti-MAG neuropathy, and there is an increasing literature on the use of those agents, which actually do suppress the immune system, in this case B cells producing antibodies, that have shown, at least based on case series in the literature, that they can help a very select and a very small group of neuropathies. Again, approach with caution. One has to have a good rationale, hopefully good basis in the medical literature, because these drugs can be dangerous, but you will find that some of these chemotherapies are being used in select forms of neuropathy. More questions?
May I have your opinion, please, on the effects of IVIG infusions?
Jessica?
Sure. Again, I think that's very similar to what Dr. Simpson was talking about just with the rituximab. It depends on the type of neuropathy. So some neuropathies are very clearly responsive to IVIG, and those are the ones that we call the inflammatory neuropathies or the demyelinating ones. We had mentioned a little bit in a previous question about CIDP, which is one kind of neuropathy clearly responsive to IVIG. Some doctors use IVIG more broadly, and the evidence that that's effective in other kinds of neuropathy is much weaker. And so that comes down to a risk-benefit assessment between the patient and the doctor. I personally do not use very much IVIG outside of the sort of stricter indications for it, because I'm concerned that it is not a totally benign treatment and has some side effects. So I'm more conservative about that, but other doctors have other practices.
What are the side effects
of IVIG? So one thing is it's an intravenous medication, so you need IV access each time. It has to be given repetitively. It's a thick substance. So when it comes into the blood, it can cause the blood to be thicker, so people can get blood clots from it, which is definitely not trivial. It can be associated with very bad headaches sometimes. It changes your immune function, and rarely there are some episodes of kidney failure from it. Pretty rare side effects, but not trivial ones.
Yes, I have 3 questions, related. First of all, how do you get on this peripheral neuropathy registry? Is there any proof at all that the nerves can regenerate, like in your feet and so forth? And does peripheral neuropathy typically get worse over time?
Okay. We'll take them one at a time if I can remember them all. We had lecture, neurology grand rounds yesterday was the memory and aging. And hopefully I'm on the normal aging part of the spectrum as opposed to Alzheimer's. The registry. We haven't said a whole lot about it today, but just to quickly tell you what this is about, I think Mary Catherine mentioned it earlier, and Lindsay can certainly talk to you in great detail. The Foundation for Peripheral Neuropathy is sponsoring this, what's called a research registry, in which we're inviting our patients that we care for clinically as patients with neuropathy, and we're focusing on 4 types: diabetic, HIV, chemotherapy, and idiopathic. And individuals with those types of neuropathies are invited to allow us to basically use the information and store the information we learn in a database, confidential, anonymous. We have 1 extra blood test for genetic testing. And we have, I believe, Lindsay, about 2,000 or so patients now nationwide in the 6 centers.
Yeah, let me pop up here. So our goal is to enroll 2,000 patients. We anticipate doing that by 2020. Obviously depends on funding like any other research project, but we're confident that we'll be able to get there by that time, including the funding. So far, we have just under 1,700 total registrants enrolled. So we're nearing the final roads. We already have several companies and institutions who have reached out to us, started to request our samples from the biobank to do their research, which is extremely encouraging. We're hoping to get more answers on biomarkers. I could go into greater detail, but I'll keep this really brief. But we are located in 5 centers, one of which is here at Mount Sinai. There's a second one at Johns Hopkins, a third one at Northwestern University, a 4th one at the University of Utah, and the final one is at the University of Kansas. So that's the only honest downside of only having 5 sites for enrollment. You have to go to one of those 5 sites to participate and make an appointment with a neurologist that is at one of those 5 sites. Now, sometimes they can acquire your records from another doctor or from another institution, but you do have to have that in-person visit so that they could do a quick workup on you to confirm that you fit the qualifications of, you have either diabetes or idiopathic neuropathy, HIV, etc. So there's a little bit of qualifications. I'll just mention we have a brochure in the back of the room, which I'd encourage you to pick up. You can also just call any of us at the foundation, or if you're located here in the New York area, reach out to Dr. Simpson or to Mary Catherine, and they'd be happy to answer any specific questions pertaining to this particular site. But that's a great question, and I appreciate you asking because it's a fantastic program and one that the foundation is really excited about. We're the only biobank in the entire world that's collecting samples for neuropathy, and we're very, very positive about finding more answers and treatments. And if you're interested in participating or donating to help make sure that we continue enrolling through the 2,000 mark, just let us know. Thank you.
Thanks, Lindsay. You had 2 other questions. Yes, nerve regeneration. So I think it might have been Shanna or one of us who talked earlier about the fact that nerves can regenerate. Very different than the brain. If you have a stroke or a brain injury, when neurons are dead, they're dead, and those brain neurons don't come back. On the other hand, peripheral nerve can regenerate, particularly the nerve endings. And we know that from any number of models, including now with skin biopsy studies. For example, I think Shani mentioned the diabetic studies, mostly from Johns Hopkins, where we see that the nerves can actually show regeneration on the skin biopsy, for example, with tighter control of diabetes. And that's now being used as a marker in research studies for improvement of nerve function. And there was a third one.
Does peripheral neuropathy typically get worse?
Oh, does it get worse? Well, it relates a little bit to the gentleman's issue here that Shanna addressed earlier about waxing and waning symptoms over the course of years. It really depends a lot on the type of neuropathy, the cause, whether we have a treatment for the neuropathy to actually impact its course. And so when patients say, am I going to get worse? For 10 patients, there may be 10 different answers, very much individualized based on what's going on with that person.
We have time for maybe one or two questions, so I'll hand it over to you.
Doctor, most of the discussion at this conference was about neuropathy and its relationship to pain and neuropathy. If I may, just to bring up a little bit of a different subject, specifically about the symptom of numbness and lack of spatial orientation of the feet specifically. As I understand it, and I'm not an expert, there are 123 different types of neuropathy that have been categorized. What specific type would be involved with acute onset numbness of the feet and lack of spatial orientation that takes place in a very, very short period of time, within no more than 1 month or 3 weeks? That's my question.
Well, he already heard my answer to it.
Okay. Shanna?
To the acute onset?
You get the tough questions.
So I
reiterate my answer, but
So I think in terms of, so the issue, a few different things. So the issue you bring up in terms of the loss of balance and the numbness and lack of spatial orientation, there's a medical term that we sometimes use to describe that called sensory ataxia. And ataxia is a medical term that means a lot of different things, but then encompasses lack of balance and coordination. And sometimes neurologists think about it as coming from parts of the brain that are involved in balance. But many patients with neuropathy know that you can have really disabling or problematic problems with balance when your brain is fine, but when the feet, with the nerves on your feet that are in charge of sensation and sensing what's happening with your shoes and with the ground underneath you, and how do you adjust your position, without even thinking about it, is really dependent on having great sensation on the soles of our feet. And so it is not uncommon that sometimes patients will come in and when I see them in the office and they'll say, I don't have burning or numbness or pain, I just have problems with balance. And I feel off balance. And it's like, could be anything. And the more we talk about it, patterns even like maybe more so in the dark or uneven surfaces where you're relying more subconsciously on input from what's happening, what can your feet feel, the ground underneath you, that's when these things tend to come out. So I think that it is an excellent and very, very critical symptom to be addressed. Some patients don't have a lot of pain, but they have kind of this numbness and lack of sensitivity and problems with balance that come along with that. And when I counsel patients on treatment, it depends sort of on what environments that tends to come up in. Again, I think the most common ones are where we can't use our vision to help compensate. So dark environments, slippery surfaces, Standing in the shower and washing your hair and closing your eyes suddenly can be very disorienting if you can't feel the surface underneath your feet very well. Getting up in the middle of the night to use the bathroom if the light is dim can be another problem area. So I actually in the office counsel patients on very simple measures like obviously footwear that's more supportive and has good grip, paying attention to environments maybe when you're walking around, going out in the evenings, especially in a day like today where it might be slippery. Would it be useful to have something like a cane, even just as a precaution? And also, in a sense, if you're sort of having a moment at home or so forth, widening where you feel suddenly unsteady, widening your feet is an instant trick to getting a little bit of a more stable base. It's kind of like if you can picture, I'm not a big football fan at all, but if you picture what they do when they're about to get ready to have somebody tackle them, they spread their feet apart because that automatically gives you a more stable base. And the same thing can be used in any moment in life. If you suddenly feel like this unsteadiness, you can actually just spread your feet a little bit more and that'll give you kind of a broader base and make you a little bit more stable. So that's a useful trick that can be helpful. The numbness, we don't have a good treatment to kind of make numbness go away. And I think you had mentioned a patient who was taking gabapentin because they thought it would treat the numbness, and in fact it really treats pain more. So numbness can be very problematic in terms of just this deadened lack of sensation, and we don't have a good treatment for numbness. But another thing that I think tied into one of my slides about Tai Chi in particular, some of these forms of exercise, they can help improve balance in the setting of this sensory ataxia or lack of balance due to lack of sensitivity of the feet, just through kind of practicing, if you will, engaging in, maybe it could be certain forms of physical therapy, but something like Tai Chi could accomplish that goal very well, just through practicing certain types of balance in a very safe way over and over again can help improve your sense of balance by allowing you to maximally utilize the other parts of your body that are working really well. And sort of maybe you start using certain muscles differently or paying attention to your environment a little bit differently and so forth. So I think that some of those other techniques can be helpful as well in terms of balance and that sort of thing. But this is a very big problem. The risk of falls, if you lose your balance, can be a huge problem that we need to all be very, very mindful of. In terms of the acuity of onset, you mentioned in your question, like how can someone go from normal to having bad numbness within the space of a month? So a couple thoughts come to my mind. There are not, the majority of neuropathies, if we take all neuropathies together, start off gradually and progress very slowly. So it would be an exception to go from totally normal to having really bad symptoms over the space of a month. There are a relatively small percentage of some of the inflammatory neuropathies or other neuropathies that can do that, but that's the exception. And again, like we've mentioned, there's specific types of tests, blood tests and patterns on the nerve conduction studies to help say that yes, you have one of these types of neuropathies that oftentimes have different types of treatment. What I would say is potentially more common in my personal experience is that patients, especially when something is slowly changing, sometimes we don't notice it as much, and then it crosses a certain threshold where suddenly people feel like they've gone from kind of being pretty normal to suddenly having overnight a really bad symptom, whatever it is. And then when we look back at their sort of nerve conductions and blood tests and physical exam and so forth, we can identify, you know what, it looks like this has been going on for a longer period of time, but maybe it was so subtle before that it just wasn't noticed or it wasn't causing problems in your day-to-day life. So I think there's a complex bag, but the point you bring up is excellent, and that is that balance and that lack of sensitivity that comes along with the numbness, which itself can be a really bothersome symptom, is important to address, and that the pain medications that we talked about earlier do not fix numbness, unfortunately. So sometimes people say, I just want my feet to feel normal, or even if they had a pain, they say, the pain is better, but my feet still don't feel normal, and it's unfortunate, but I have to say we don't unfortunately have a medicine that will return that normal sensitivity, but I hope that someday we will.
Great, and we have one last question before we wrap up. And by the way, I do want to thank all of you for spending your time here with us this morning. It's very, very valuable and very important. And speaking of which, before I ask the question, I am one of those people who's been followed with subsequent skin biopsies, and I have shown regeneration, so it can happen. My question today and concern, and those of you who know me know this is one of my pet peeves, is basically directed not only to the people up on the dais, but everybody in this room, which is basically how do we make people understand that this is a condition, and how do we make sure that people know about it? It certainly has impacted on the ability of people to undertake research projects, certainly has impacted on the knowledge of doctors as well as lay people to actually know about the condition and provide initiatives for it. And it seems to me that this is one of the biggest problems that the field actually faces beyond the idiosyncratic things of how to set up particular research paradigms. Just as an example, I will tell you right now, my wife is doing a lupus walk with the Lupus Research Association. Lupus, which has far fewer sufferers than neuropathy, has 4 major national organizations with about 97 full-time employees. As you can see, you know, our neuropathy associations do not have anywhere near that, and it's simply because the condition is not known about. It does not have the publicity. I'm looking for suggestions. I've certainly received some, making films, doing TED Talks, getting celebrities involved, but I'm really interested in how we can actually get this some more publicity.
Well, you're talking to an audience of the converted, because by the nature of all of us being here today, we're doing our small part to address exactly the issue that you bring up. Certainly Lindsay and Lou and the Foundation for Peripheral Neuropathy are playing a very big role in addressing exactly the points you raise. But I think the central concern is a valid one, and that is when you think of the general public and even the medical community in terms of primary care physicians, neuropathy is not high on people's radar screens. And why is that? Well, one thing is it usually doesn't kill you, and so it doesn't have that cachet and that kind of, wow, if we don't hit this right now, a lot of people are going to die. It's a quality of life issue, and unless a person or a family member or an acquaintance is affected, it's usually not going to come into people's attention. Now, the pharmaceutical industry is doing their part, partly because of their incentive to sell their drugs. So we're seeing things like Lyrica and Cymbalta being advertised. But we could probably spend a whole day on addressing the points you raise on what strategies could be used to improve awareness, publicity, research, fundraising. But I can tell you that the foundation that's sponsoring today's symposium has that as their central mission. And we need to do a lot more, but you have to start somewhere. I know, Lindsay, if you wanted to end with any comments, that might be a good segue for you.
Yeah, thank you. This is a huge issue, awareness building for not just peripheral neuropathy, but also us here at the Foundation for Peripheral Neuropathy. An estimated 30 million Americans alone have neuropathy. To put it into context, we have, I'd say, 60 or 65,000 people that we know of in our database. So I don't know what the math is on that. Small. It's small. So that's our problem, is that we don't have enough people that we know about, patients, who would find our resources valuable. So how do we get them to know about us? So we're trying to, go on emails and our website, social media. We're trying to help spread the word, but we also rely heavily on each of you, not just in this room and watching us live right now, but each of you to do your part in talking about this condition, what it means to you on a daily basis, how it's impacted your life. Don't be embarrassed about it. This is something that is affecting a large percentage of the population. And I think it's healthy to talk about it, to find answers, and more importantly, to educate other people about what it is. I think so many times People don't even know how to spell neuropathy. They don't even know what it is. When I call people on the phone, they say the Foundation for sorry, what? So, I think naming the condition what it is, not just saying it's nerve pain, because guess what? Not everyone in this room has pain either, but it is a neurological condition. So I think there's so much to do, and we're way out of time, but what I'll leave you is this, it is our mission here at the Foundation, me and the staff, our board members, our scientific advisory boards, the neurologist standing alongside me right now, and the numerous other support that we have across the nation and across the world. We want to help you. We want to educate everybody, not just you, but the people you live with, your neighbors, your friends, your coworkers. And if we're successful in doing this, and we will be, it's just a matter of when, we will have money to do more research. We will have money to do more programs. We'll be able to be greater than a staff of 3 at some point. We'll be able to spread more into the local areas than just being able to, do the emails and do the mailings that we do. So we have our work cut out for us, but I assure you that the Foundation is here for you. We hear you, and we're trying every single day to make it just that one step closer to finding all of those answers. If you have any interest in helping us, as I mentioned earlier, volunteering, sharing insights, tips, thoughts, please, we want those thoughts. We welcome them. So on that note, thank you so much. If you did have questions, or especially for those who are watching us online that had questions that we weren't able to get to, I sincerely apologize. But please send those to us through email. Find us before we, head out for lunch right now. We're here, we're happy to talk. And if you don't have time to do it today, or we can't find a time to connect, we're back on Monday. This is a full-time position, so just feel free to let us know. Again, thank you so much for coming. Thank you to our sponsors. Thank you to everyone who watched us live. We will be having a recording of this event, in case you happen to nod off, available in the next couple of weeks. I'm not looking at anyone. Dr. Simpson. But we will be making that available, so stay tuned. And in the interim, like I said, if you have any questions, just let us know. Thank you again. Thank you, everyone.